Good morning, everyone. Good morning. Oh, wow. It's so nice to be here with all of you in person. So I'm Shirley Kessel. I'm the Executive Director of Miles for Migraine, and I want to welcome you here in person. And we have a virtual Zoom going on at the same time. And this is our third hybrid event in a series of education events that we wanted to put on for many reasons. But before we get started with that, I just want to thank our sponsors, both Amgen and Lundbeck, who have made this program possible. And we do have a representative here today in the back of the room, and I really encourage you to please check out information, because as a person living with migraine or headache disease, we don't have all the information that we can get from our providers. Most of us are lucky enough to see a fellowship trained headache provider. And if you're one of those people, then lucky for you. And the reason that's important is because migraine's a very complicated disease. And how many people here today in this room had to wait more than 6 months to get a diagnosis? Okay, almost everyone's raising their hand, and I include myself in that. I have chronic migraine. And so why do you think that happens? Well, I can share with you why that happens. Migraine's a very underdiagnosed, misdiagnosed, and under-researched disease. And so are other headache diseases, not just migraine. And many of you here today might have other diagnoses besides migraine. And the reason for that is because traditionally migraine is mostly a women's disease, and there are men obviously with migraine and headache diseases, but much of the research was overlooked in migraine because it was thought of to be in the history. If you look back in the history books about migraine, it was thought to be a wealthy white woman's disease. And that's because women who had social benefits of being wealthy and able to stay at home were the ones that were always talking about their headaches. And when they went to their doctors would say to them things like, well, you're just not performing all your social duties enough. You just need to go home and have more sex with your husband. And I'm not kidding. That's really true. That's actually true. And so this stigma has really pervaded in our society for many years. So I want to see a show of hands again. Come in and sit down. How many people in this room have ever heard someone say to them, just drink more water, just reduce your stress? Oh, I get headaches too. Everyone's saying yes. And if you haven't, well, good, then you are very lucky. So today, the reason why it's important for you to be here is not only is it important, and you're going to hear from amazing speakers this morning about migraine diagnosis, treatment, and even living with migraine and how to cope with all the things that we face, because we don't just face chronic pain. There are a lot of comorbidities with migraine. There are other symptoms of migraine and headache disease besides just pain. And how do you live your life when you're constantly worrying? Okay. How many of us worry about when the next attack is coming because we don't know? And the other part of migraine is not just the medical treatment side. It's important for you to understand that if we don't all raise our voices collectively together and advocate for this disease, we are not going to get more research, more funding, and better outcomes. And we want our insurance companies to pay for these medicines. There is a new class of medicine that many of you are maybe on this new class of anti-CGRP medications. And there was an announcement last week by the American Headache Society, who is the training and oversight for headache specialists in the country. The Headache Society is where doctors go to get their education and stay up to date on their training. And they made an announcement that this new class of drugs, the anti-CGRPs, should be first-line therapy. Now, that's important for all of us, because right now, raise your hand if you started out on a drug such as a beta blocker or an anti-epileptic drug. Yes, right. So those drugs were not researched and developed specifically for migraine. Those are drugs that were found out to help headaches, but they're not designed for migraine. On the prevention side, the first class of drug just came out on the market 6 years ago. So it's important for all of us to understand that if we want to get more drugs, because not all of these drugs work for all of us, we need to keep fighting and we need to raise our voices. And so one way you can do that, it's up on the screen right now. We have a walk run here in Milwaukee in August. I encourage you to please, August 10th. If you're watching us virtually, you can also participate virtually in this event if you're in another city. And if you are unable to attend on August 10th, we have other ways for you to advocate. You can go to our website, please register for our newsletter, and we will share those resources with you on how to have your own little event. So simple. You can even go to your favorite restaurant and ask them, say, hey, I want to invite my friends and family to come to your restaurant. Would you be willing to give back a percentage of sales to us? And most restaurants will do this because it increases their foot traffic. So we have a whole range, though, of ways for you to be more involved. And on the support side, we have these education programs all the time that are virtual. I encourage you to go to our website. Many of these education events are put on by fellows trained by the American Headache Society who have fellowship training, and we have them all on YouTube, and you can go and watch those for free. We also have support groups and we have social groups. And so we have some fun events coming up. We have a book club coming up in the summer, and we've got some game nights, so please check it out. So today we are going to first hear about migraine diagnosis and treatment, and then we will have a presentation by a pain psychologist. And we will also have a presentation by a patient advocate who will talk with us about how to tell your elevator pitch. And the reason this is important is because when you encounter someone who says to you, well, I get headaches too, or just drink more water, or what do you mean you have another headache? You just had a headache the other day and you couldn't come to the party or to work. What do you say to that? Right? Don't you feel a little shut down? Like you don't really know what to say because you feel like you are letting people down all the time? Well, guess what? It's not your fault. And unless you speak up and really have a good elevator pitch on how to work with stigmatizing comments, or to just talk to your mother, your grandmother, your aunt, your uncle, whoever that doesn't understand why you have these headaches and thinks that you are just complaining a lot. If you don't speak up, then the landscape of migraine will not change. So we are all here together and we want to do this together and we want to support you in this. And guess what? You can do it because we have an advocacy training program called Act Now. And Dr. Schlemer went through the program, and Jennifer, you went through the program too, right? So she's in the program right now. And we train fellows and we train patients. And you can go to our website and register for that also if you want to become a more senior advocate in the community. But maybe Dr. Collins will talk a little bit about that, about your experience. And so that's why we want to train you in how to tell your elevator pitch today. And the other thing we want to share with you, and this will be experiential, we don't expect you just to sit here and listen to us all day. We're going to ask you to get involved and talk to your neighbors. I will also be presenting to you on how to talk to your healthcare provider, because there's a lot that goes on in that very short amount of time that you have to talk with your healthcare provider. And unless you have all the tools and resources, then you might find out that you're not maybe getting all the treatment that you could receive or the best treatment you could receive. So we'll talk about that as well too. So let's get started. I want to first introduce uh, our two physicians in the room. So first is Dr. Schlemer. She's an associate professor of neurology in the Department of Neurology at the Medical College of Wisconsin here. She joined in 2015 as faculty. She is presently the director of the Headache Medicine Division and associate program director of the Adult Neurology Residency Program at the Medical College of Wisconsin. She is also the medical director of the Neuroscience Clinic at Frater Hospital. Dr. Schlemer received her Doctor of Osteopathic Medicine from Chicago College of Osteopathic Medicine, and she completed her neurology residency and her headache medicine fellowship here at the Medical College of Wisconsin. She is a member of the American Academy of Neurology and the American Headache Society, and she's an active participant in education activities and events for patients, medical students, residents, and fellows, and she was very instrumental in getting this program here today. And I also want to welcome Dr. Jennifer Collins, who is a fellow here in the Department of Neurology here at the hospital. She received her medical degree from the University of Wisconsin and public health in Madison with an emphasis in rural medicine. She completed her neurology residency at MCW, and she also served as chief resident of the adult neurology program. Dr. Collins is currently headache medicine fellow at the headache medicine fellow here, and she will be graduating in June. So let's welcome our two doctors. Yeah, I'll go on this side. Yeah, it's just more natural on this side.
There we go. Good morning, everybody. I'm Fallon Schlemer, and this is Dr. Collins. We're super excited to have you with us this morning and spend your Saturday getting to know us and share your stories with us and getting to learn about migraine. And I want to take this opportunity to thank Shirley and Miles for Migraine for bringing this event to Milwaukee. We're super honored to have you guys here, so thank you. So today, Dr. Collins and I are going to talk to you about migraine diagnosis and treatment. Just some housekeeping things. I'm a speaker for Eli Lilly and AbbVie.
And I have no disclosures at this point in time, maybe in the future.
All right.
So thinking about migraine and thinking about how do we diagnose migraine, and frankly, how do we even identify migraine in the general population? You know, people hear all the time, oh, I have headaches, or, you know, how do we get to the migraine diagnosis and point? And so in 2003, researchers had conducted a study to see if they could identify characteristics of migraine that could be used in a self-screening tool for patients with headaches. And it was kind of the idea of using it in a primary care clinic to try to accurately predict migraine. So how can we go from I've got headaches to, wow, I think this is a migraine diagnosis? And so they evaluated 9 characteristics, and 3 jumped out as being able to accurately and reliably predict migraine in patients with headache that didn't have a formal diagnosis. And all of the patients in this study were then did see a headache specialist, so a certified headache specialist to receive a diagnosis. And they found that the 3 kind of characteristics that really, you know, gave us kind of good evidence that this is a migraine are feeling nauseated or sick to your stomach during your headache. Did light bother you during your headache? And have headaches limited your ability to work, study, do social things, do whatever you need to do? And if you guys think of your migraine headaches, I bet you can check all 3 of these boxes, or at least 2 of these 3 boxes. And I'm sure a lot of you push through as best you can But if we're honest, yes, this is definitely limiting my ability. And so this is kind of something we always look at, and we try to talk to people about, are these three things happening with your headache? If they are, consider a diagnosis of migraine.
All right. And so when we first evaluate patients in the headache clinic, the majority of our first visit, we spend a great deal of time getting a good headache history, because that's how we diagnose what type of headache a patient might have, right? And the majority of the headaches that we see in the headache clinic is migraine, but believe it or not, there are hundreds of different types of headaches. But as you know, we're talking about migraine today. And the two main types of migraine are migraine with and without aura. So your common type of migraine is the migraine without aura. So these typically are migraine headaches that last on the order of hours. So these can be several hours, even days of headache that is often unilateral, is that pulsating, like that throbbing, like heartbeat in your head, often of the moderate to severe intensity of pain, often aggravated by physical activity. So just simply like walking up the stairs or down the stairs can make the pain worse. And you have to have at least one of the following. So nausea and or vomiting, photo and or phonophobia. So that's light sensitivity, sound sensitivity. So one thing I want to point out about this is that you don't have to check all of these boxes to meet criteria. So a lot of times patients are underdiagnosed as having migraine because, they might say, well, I think this is more of a tension headache because it's bilateral. But if they are nauseous and it's very severe, that's migraine. So again, you don't have to check all these boxes. And then we have migraine with aura that affects about 20% of patients. This is migraine headache that's often preceded by this neurological phenomenon, typically visual, but it can be really any neurological phenomenon. Often the visual aura is of these like scintillating scotomas, the fortification spectrum, any sort of like visual disturbance. These typically last anywhere between 5 and 60 minutes, come on gradually. When we worry about migraine with aura is when the aura is lasting longer than an hour. That's when we kind of worry about maybe secondary causes, because by definition, migraine is a primary headache disorder, not coming from something secondary, like a tumor or something. It feels like it is because it's debilitating, right? And we might rule those out, which we'll talk about later. But an aura can also be something like sensory, like numbness or tingling in an extremity, weakness, trouble speaking. So it can be a whole host of symptoms. All right, so what are the phases of migraine? So this slide really highlights to me that migraine is not just a headache, right? So when I ask patients about migraine, I'm asking them, how many days a month are you dealing with symptoms related to your migraine? Because it's not just the headache. So there's up to 4 different phases of a migraine, and they can really be described using emojis. So often a migraine can start with this prodromal phase or premonitory phase, which can occur hours to days leading up to your migraine. I too get migraine. My prodromal phase is I get this neck pain. So a lot of times when patients get that too, they think, oh, do I have a neck issue? And is that why I have headaches? Well, no, that can just be where your migraine is starting. Or yawning is one of mine too, but it can be really anything. Change in mood, irritability, food cravings, all your sensitivity starting, your GI stuff, all that fun stuff. And then again, in 20% of the population can have that aura phase. And then that's when the headache ensues thereafter, right? And then you can get all those other fun symptoms along with the headache. And then when you think you're in the clear, after your headache resolves, you still feel like, pardon my language, crap, which can last 24 up to 48 hours. And this can be, still changes in your mood. Some people have this sense of euphoria where maybe their mood's a little bit better and they're feeling more productive, but then you can still have a lot of other unpleasant issues.
So this is just kind of a diagram and schematic to show you of migraine sufferers. Where does everybody fit into how many headaches they're having per month? And this is just migraine per month. We do know that people with migraine a lot suffer from kind of chronic daily headaches with migrainous features as well. And so this doesn't take into account that people might be having, 1 to 2 to 4 severe, but then every day you just have something. But a lot of people fit into the 1 to 2, 2 to 3, even the 4 to 6. But you can see we start to get to 7 to 9, 10, and there are still a big percentage that fits into the 6 or more, or 4 to 6 or more. And so as we get into kind of the having more headaches per month, you start to have a higher incidence of other conditions, mental health conditions, anxiety, depression. When you're in pain for that many days a month, your mental health is going to suffer. I mean, you can't get ahead of this pain, and other kind of chronic pain as well. And so as the number of monthly headaches goes up, so does the migraine related disability.
So just some definitions. So what is chronic migraine? So chronic migraine by definition is you have to have 15 or more headache days per month, 8 of which meet that migraine criteria. So not all of those days have to kind of meet migraine diagnosis. So it's kind of mixed picture, and it has to have been going on for at least 3 months. So that's just kind of what we use as clinicians to kind of meet this diagnosis. And believe it or not, this affects a lot of people. We see a lot of this. But to complicate things more, you shouldn't be able to read this because it's complex. So there's a lot of different subtypes of migraine. So chronic migraine is just one subtype of migraine. We already talked about migraine without aura, migraine with aura, but then we have all of these other subtypes like basilar type migraine, hemiplegic migraine, complications of migraine, status migraine. Maybe some of you have suffered from migraine that has been lasting days and it's been refractory, and now we're looking at IV treatments to try to break it. So again, it's migraine is not so simple, right? All right. So one thing, like I mentioned earlier, migraine is a primary headache disorder, meaning, again, it's not coming from something structurally wrong with the brain. That being said, the migraine brain isn't normal. There's things happening on a neuronal, cellular, hyperexcitable level. Thanks, Shirley. That's causing like lights for it to fire. But we always want to make sure we are addressing red flags or potential things that could, lead us to be thinking about secondary causes of headache. So even when you have migraine, headache patterns can change. So we want to be aware of these. So certain things that alert us to headache red flags. So systemic symptoms. So anytime there's like a change in headache pattern associated with fever or weight loss, we want to be thinking, could there be something else going on? And this is what we call our Snoop mnemonic. And you'll see why it's called Snoop, because the letters spell out Snoop.
We like to do a lot of mnemonics in medicine because it helps us remember things.
Yeah, but then you forget the mnemonic and you're like, wait. Secondary risk factors, so like if there's a history of malignancy, HIV, other sort of conditions, and now we're having headache, could that be related? Neurological symptoms or signs. So if now we're presenting with, changes in our neuro exam or, other kind of neurological symptoms, that gets us concerned that that's what the headache is stemming from. Sudden onset of headache or abrupt onset of headache, these like thunderclap headaches, that could be a sign of a secondary cause of headache. That being said, there's a lot of primary causes of thunderclap headache, such as primary cough headaches. I have some patients who just get headache with coughing, sneezing, taking a poop, as weird as that sounds, having sex, so unpleasant, but those are not from something secondary. So just again, we're asking a lot of questions when we're seeing patients so that we can make sure we're diagnosing the appropriate headache type and treating it. Older age of onset. So typically headaches, new onset headaches shouldn't occur as we get older, or we get kind of worried if it does. So we always want to rule out a tumor, God forbid, or something, but certainly migraine, other headaches, it can happen. But again, we're gonna make sure we're not missing something. So we're always asking about previous headache history. This is again, first time, like we talked about in someone who's older, or change in pattern. So I always personally have a low threshold to maybe get a scan or other workup if my migraine patient who's always had these certain type of headaches is now coming with completely different type of headache or new features to their headaches. Just because, maybe something has changed. Papilledema, this is kind of swelling of the vessels behind the eyes. This could indicate high pressure in the brain. Often we have our neuro-ophthalmology colleagues take a better look at this for us. And then precipitated by Valsalva. So this is things like bearing down, like I mentioned, having a bowel movement, straining, that when you do those things, that could increase your headache, that could be a sign of something serious. But again, there's certain primary headache disorders that is normal and not coming from something secondary. And then postural aggravation. So if headaches are worse sitting up and then relieved laying down, or vice versa, that could be a cause for a secondary headache. Okay. Treatment. What's involved? Is my slide? Okay. Treatment. What's involved? Okay. So what I love about my job as a headache specialist is it involves a lot of patient education and counseling. That's truly what I love a lot about it. So often patients come to me and, it's the first time someone has actually acknowledged you have migraine, you have a neurological disease, it's not a tumor, or, finally you want to listen to my headaches. You want to hear me out? Like, yes, I want to help you. I want to hear your story. I'm ready to help. Right. So what's involved? Treatment or education, reassurance that this isn't just in your head. You don't need to just suck it up and drink some more water. I'm ready to help you. So avoiding triggers. So we always tell patients from day one and moving forward, keep a good old headache diary. Of course, if there's apps for everything now. So Migraine Buddy is a free app you can download. Otherwise, if you're old school like me, good old calendar or notebook. Because, a lot of migraine management is trigger avoidance. Some triggers are unavoidable. So here's, some simple ones. Some of these might look familiar. Maybe pop-up PowerPoints are a trigger for you. I'm sorry. And then non-pharmacologic treatments, which we'll talk about a little bit later here with my colleagues, but relaxation, meditation, cognitive behavioral therapy, biofeedback, a lot of good evidence in the literature and, anecdotal evidence, physical therapy, acupuncture, massage therapy, et cetera. All those things can be helpful. Lifestyle regulation. So maintaining a regular schedule, getting good sleep and exercise, all these things are super important. Stopping smoking, we do know definitely that's triggered chronic migraine. Treating sleep apnea, super important. So we're always screening patients regarding, their sleep. And then comorbid conditions as well. And advocacy programs, these are super helpful. And then pharmacologic treatment, acute and preventative, which we'll talk about in detail. So our goals in general of treatment. So we obviously, we want to restore patients to a normal functioning in a safe, side effect-free manner, trying to be cost-effective manner. Sometimes with insurance, it's difficult. We've really tried to minimize the need for additional medication exposure through the use of the ED. We really try to avoid that as much as possible. Because that's the last place you want to be when you have a migraine, is in the ER with all the bells and whistles and waiting for hours when you're suffering, right? Reduce the frequency, duration, and severity of each attack. I always tell my patients that my goal when you have a migraine is that your headache is gone within a couple hours and you're back to your fully functional self. And we can try to get that way. We want to reduce progression of disease. So with those frequent episodic migraineurs, we want to reduce progression to that chronic migraine. So let's get aggressive at how we treat. And then obviously reduce disability.
And we wanted to take some time to talk about the stigma of migraine, because this is a huge problem and in itself can contribute to, quality of life and problems that everybody, kind of has, and even mood and mental health and everything too. Living with migraine means facing misconceptions and lack of awareness about migraine. And, we've mentioned it before, but, oh, it's a headache. Take some Tylenol. It'll be fine. I have headaches too. I just do this and then it's fine. And so it's just misconceptions. People just don't understand. So stigma is defined as negative and often dismissive attitudes experienced by people with a specific medical condition. So it's any medical condition. And, migraine is a medical condition. So it fits right into that category. In the case of migraine, it often takes the form of negative reactions and a lack of understanding when someone is unable to meet your social or professional expectations because of migraine symptoms. So many of my patients, I actually, there was a school teacher the other day who was saying, I don't know what to do. I, just had a really bad month and I had to have a lot of subs, and my coworkers, some of them were understanding, but some of them were saying, why can't you just come in? And, the school was trying to get subs and everything. And it was just, it was very demoralizing, and it was very difficult for her to deal with that. Stigma can make people feel invalidated, discouraged, and it can even cause people to second guess their own diagnosis, their own symptoms. And this discourages people from, sharing stories and experiences. People begin to believe that they're not a good parent, they're not a good worker, they're not a good, whatever you have to do in your life because of these migraine symptoms. And that's absolutely terrible. And it has a major negative impact on not only the ability to manage migraine, but also mental health and all of the symptoms as well. And so when we think about stigma, there's a lot of stigma, but we think about societal attitudes, negative, dismissive attitudes toward migraine, toward symptoms and everything like that. And then also structural laws and policies in place. And that has to do with how much sick time do you get? What's family medical leave? What can you use family medical leave? Do you have to use your sick leave for that? Do you get to a point where they're like, oh, you're just going to have to take unpaid time? Things like that. So it's not just the societal, but it's the structural, the laws and policies in place. And it leads to all of these things: low self-esteem, depression, more pain, concealment, even sometimes low participation rates in treatment, because you start to get to the point where you're like, well, why bother? This isn't going to work. So combating stigma involves a lot of different things, interventions designed to help people change their thought processes, develop skills to cope with this disease, and also to be able to talk about this with others, to try to explain to others, this is what is happening. And I want to tell you what I'm going through so that you understand this. And so basically, kind of working on this involves interpersonal therapy, self-advocacy education, like today, the stuff that we're going to do today, and building a strong support network. And we'll talk about this a little bit later in terms of the advocacy, but we also have someone who's going to help us kind of talk about what is the pitch that we can give to others when they kind of say, oh, migraine, what's that?
All right. So moving on to treatment. So in regards to treating headaches acutely or migraine acutely, so we really try to tailor each, treatment regimen to the patient. So, we here at the medical college, we train a lot of medical students, residents, fellows, and I often get the question like, what's your go-to rescue medication, or what's your go-to preventative? And I'm like, I don't have a go-to. Like, it really depends on the patient, because we're factoring in, their other health issues, other medications that they're on, all of these things. So really, again, we're tailoring treatment to both the patient and what their attacks are like, what symptoms they're getting with each attack. So things that we're looking out for. So recognizing their triggers and how to mitigate them, treating early in the attack. So this, if I had a quarter for how many times I heard a patient say, I think I'm just going to wait because I only get 9 triptans a month, and, maybe it won't be that bad, so I'm just going to wait. Well, but if you wait, 10, 15 minutes even into the attack, it might be too late, and it's not going to work. So now you're too late. So right at the onset, even there's evidence that treating during that prodromal phase that we talked about will help ward off that headache. So treat as soon as you get an inkling that you're going to get your migraine. It's important to use adequate dose and formulation of the medication. We also see this too, where, a patient might be on a smaller dose of, let's say, their sumatriptan, because that's just what was comfortable with what was prescribed, but more is needed, okay? Or the correct formulation. So in someone who is really nauseous or throwing up, or even someone who's not terribly nauseous, we do know that the gut mobility slows down during a migraine attack. And so taking a big honking pill during a migraine attack might not be the best option because it's not going to be absorbed during a migraine attack. So we want to bypass the gut, do an injectable or a nasal spray or something like that. So like, that's how we're thinking, okay? It's important to restrict the use to on average a couple days a week to avoid this medication adaptation or overuse headache, because we don't want patients to have to take their rescues every single day, because that could lead to more headache or refractory headache. So then patients look at me like I have 5 heads when they have daily headache. Like, what do you mean I can't take something every day? Well, then that's when we have to be more aggressive about prevention, which we'll talk about. I already mentioned the bypassing the stomach. I'm getting ahead of myself. And then again, considering comorbidities when choosing medicine. So we're not going to prescribe something that could interact with other medications or make other problems worse. And again, focusing on non-pharmacologic treatment. So it's really important when you have a migraine that you might need to rest, right? You might need to remove yourself from the stimulating environment, use cold compresses. I mean, it's important to hydrate. I mean, again, we're not saying, just drink water, that's going to solve it. But, it's important to add that to the mix of treatment. Relax, biofeedback, meditation. Again, we'll focus on that. Devices can be additive, which Dr. Collins will talk about. Okay, so what are our arsenal of acute treatment options? So here's just a table for your reference. So kind of our historical go-tos for acute treatment, specifically for migraine, have been the triptans. So there's 7 of them: sumatriptan, rizatriptan, elatriptan, zolmitriptan, elmotriptan, naratriptan, frovatriptan. And all of them come in various different formulations. Some are a little bit more versatile than others. So sumatriptan, for example, comes in an injection and nasal spray. It used to come in a needleless injectable called Sumavil. Rizatriptan, I personally like that for my migraines. It comes in a dissolvable tablet, a little minty flavor. Zolmitriptan also comes in a nasal spray. So they all have like different formulations. Naratriptan and frovatriptan tend to be a little bit longer acting. So again, depending on how a patient's migraine is behaving, that might kind of dictate, which one we decide to choose. Then there's DHE, which is dihydroergotamine. That can be used as a home medication via a nasal spray, like Migrainol nasal spray. Sometimes we'll give it as a home injectable. We'll inject that in the office, as I am for like a refractory headache. It's commonly though used as an IV medication for status migraine. So we'll do the Raskin protocol and we'll schedule that via IV infusion to help break a bad headache. There's this newer agent called lasmiditan or Rayvow. That's one of the DTANs that acts at one of the serotonin receptors that is also used. Then we also often combined these with our simple analgesics. So various different NSAIDs, some of which are mainly just used for rescue, but some of which we also use as a preventative in certain headache types, like indomethacin. Then we have also adjuncts that we use to help mitigate gut motility, nausea, listed here, like ondansetron, which is Zofran, if that sounds familiar, or metoclopramide, that might sound familiar to you guys, brand name Reglan. And then we have our newer agents, the GPANs, ubrogepant, rimegepant, sevegepant. These have really changed the landscape too with migraine, as these are our CGRP antagonists. So historically, we would use the triptans, which pathophysiology caused some vasoconstriction or narrowing of blood vessels. So in patients where they've had like coronary artery disease or history of stroke, which we tend to have to avoid things like the triptans, these we can use in those patient populations. So that's exciting for us as headache docs, where we've had limitations to some of the medications. And then complementary, again, mindfulness-based practices, devices, essential oils, natural supplements, ginger, caffeine. Again, more little devices like green lights, lenses, and I think my friend Sarah over there has some personal anecdotes on those.
And we talk a lot about other kind of non-pharmacologic treatment, and completely understanding that I doubt any of you could do these and migraine is gone. Maybe sleep, that's about the only thing, but not everybody. You can't in the middle of the day, just you're at work and go to sleep for 5 hours and then, migraine is gone. But both Dr. Schleimer and myself, what I have learned from her is that you need options and lots of them. You know, I would love for one medication to just completely take care of everything, but that's usually not the case. I'm sure a lot of you have tried lots of medications and they haven't worked. And maybe some of you are still trying to find that treatment that's going to help. And so we just love to give people lots and lots of options for what they can do, including mixes of medications, including non-pharmacologic treatment. You know, maybe some of these are going to help. And one of the things that I've kind of gotten into learning about more with Dr. Thumala, our pain psychologist, who's going to talk after us, is the kind of biofeedback and pain psychology and meditation and kind of things like that, the mind-body connection, which have been shown to be very helpful as well. I'm going to kind of gloss over this just very, very briefly because I have a slide later that shows kind of some pictures of these things, but you may have heard of some of these new devices that deliver like a very small electrical current. You wear it on the forehead. There's one that straps around the arm. That's one that stimulates a nerve in your neck. And the idea with all of these devices is that when you have, when someone has a migraine, the pain pathways are just going crazy. And the idea with these is to kind of try to interrupt the signaling of the pain pathways and reset the signaling of the pain pathways. And unfortunately, these are not covered by insurance companies yet. I don't know if any of them are covered. Now, these device manufacturers do have payment plans. They do have various, parts. And if you kind of look online for, some of these, you'll be able to see some of these different things. Some of them have money back guarantees. Try it for a month or 60 days. And if it doesn't work, all you have to do is pay for these pads that go on your head or pads that go on your arm. So they are kind of worth a shot. And you can ask your doctor, more about any of these. And then do want to talk about rebound headache or medication adaptation headaches. We're trying to get away from the term medication overuse headaches. I really don't think anybody is trying to overuse medications. People are not saying, yes, I would love to take ibuprofen every single day. But a lot of patients, and especially patients that come to us for the first time, that's all they have. They're having a daily headache and all they have is ibuprofen. They don't have anything else. They don't have a preventative, a triptan, or anything. So we really are trying to get away from medication overuse headache, but if you Google it, that's what you're going to come up with. So we like to call it either rebound headache or frankly, medication adaptation headache, where, your body is kind of adapted to having this medication. And so it's getting used to it. So there are kind of some limits to medications. Now there's always, exceptions to the limits. Triptans is kind of like 8 or 9 days. I think a lot of times people get like 9 of sumatriptan, and sometimes insurance is going to limit how much you're going to get as well. Over-the-counter medications like to limit to 15 days per month. And frankly, the GPANs like Ubrelvy, Nurtec, we don't know yet. We're not really seeing medication, adaptation headaches or rebound headaches. So maybe in the future, insurance companies will start approving more of these and, they can be used a little bit more. So we just kind of talk about trying to avoid, but we also understand as providers, we understand that if someone doesn't have a good preventative on board yet, we're gonna work to try to see what we can do in terms of getting more acute treatments on board. And then, migraine healthy lifestyle, we can kind of both talk about these. You guys probably know it's not easy, but it involves so many different parts to your life. I'm sure a lot of you can say, if I don't drink enough water, get enough sleep, or if I eat certain foods or do things, it's not going to be as good. Moving around, trying to develop a routine that can maybe help and not instigate a migraine, because a lot of people say, oh, if I go work out or I weight lift, I know a migraine is going to come on. Self-awareness, we're going to talk about this, the mindfulness, the relaxation, meditation, engaging with people. And that also has to do with just like-minded people. You find people who have migraine and the two of you can talk and You know, it's just, it becomes more empowering because you're not alone. Self-efficacy, we're going to talk a little bit about that today too, in terms of, you know, being able to kind of talk about these things. And then, you know, seeing setbacks as learning opportunities, but a lot of this is easier said than done. It really truly is. We understand. I don't know if you.
There we go. Okay. All right. So moving on to preventative therapy. So when do we consider starting a preventative treatment? So honestly, any point in time. I mean, as few as a couple headaches a month, if they're debilitating and getting in the way of caring for your kids, you're missing work, the patient might just prefer it. That might warrant being on a daily preventative. Sometimes if our acute medications are ineffective, so even just with those couple of days a month, like no matter what we've tried on the acute side, it's just not working. Maybe we need that preventative boost to get our acute therapies to work. Or we have a lot of contraindications to some of our rescue medications. So now we need to focus more on the preventative side. That might be a reason. Special circumstances. This might be in those folks that I mentioned earlier who have these other unique migraine types, like the basilar type migraine or the hemiplegic migraine, where we are a little bit more limited as to what rescue treatments that we can use. So at really any point in time, we will consider a preventative therapy. So principles of preventative therapy. So it's always important that we don't really start at the highest dose possible of a preventative and then have patients have side effects and then we're done, you know? So we always want to start at the low dose and kind of work our way up slowly, which can be a little bit of a struggle sometimes because, you know, when you're living with migraine and you're suffering, you want quick relief, but it'll take some time until we can find a regimen that's going to work. And we also want to give it adequate time. So a lot of times these medications at a therapeutic dose can take several weeks to months. So oftentimes we'll hear folks call in and be like, it's been a week, I'm not feeling any relief. Well, that's not unusual because again, it can take weeks to months. And I know that's really frustrating because, you know, you're dealing with pain, right? But it can take time because it's acting on neurotransmitters and such and trying to adjust those connections in the brain. Obviously, we are looking at your other medications that you're on. We want to avoid interactions, contraindications, and we're considering other medical conditions you might have because we don't want to make other things worse. We're constantly monitoring our improvement or lack thereof with the headache diary. So it's important to continue to keep those diaries that we talked about. We might need to consider combinations in patients who are a little bit refractory. So it's not unusual in our chronic migraineurs that we have patients on a couple different agents. They might be on a couple oral meds. They're also getting Botox. They're also maybe on a monoclonal antibody, monthly injection. That's not unusual. And we might consider tapering certain ones when headaches are controlled. But again, it might be potentially lifelong because migraine is a neurological disease, right? And it might be something that we need to maintain. But we can always consider pulling back when patients are feeling better and say, okay, what might not you need anymore? We can see. Because that question does come up a lot. Like, well, I need all this forever, you know? So what are our preventatives? So historically, a lot of the medications that we have used for migraine prevention aren't specific for migraine. So we use anti-seizure medications listed here, antidepressants, blood pressure medications. And again, how we pick and choose which ones to use are based off of like what makes the most sense for the patient. So if I take the antidepressant family, not saying migraines from depression, but they work again on, you know, neuronal connections in the brain and neurotransmitters to help migraine. They've been found effective at treating migraine. But in someone who might have maybe underlying mood disorder or issues with sleep, falling asleep, staying asleep, this is a great class because things like amitriptyline, nortriptyline are really effective at treating sleep because they can be sedating at night. However, potential side effects include weight gain. No one likes that. And some what we call anticholinergic side effects. So like dry mouth, dry eyes, constipation. So in people who already are susceptible to that, you know, that might not be the best option. So we're thinking through all of these things when we're picking an agent. The anti-seizure medications, one that we commonly use in this class is topiramate, the first one. This is one that I always educate patients that it can cause what we call cognitive clouding. So just to kind of be mindful of that. It also can cause weight loss. So usually when I tell patients that, they're like, sign me up. But that's a common one in that class. We use a lot of blood pressure medications because those have been found effective at treating migraine. Botox is a common procedure we do in the headache clinic. It's very effective at treating migraine. What's nice about it is that it's not another pill, side effects of another daily pill. But now, to fast forward more recent years, we've come to know so much more about the pathophysiology behind migraine. And what we think is a main driver for migraine pain is this protein called CGRP, calcitonin gene-related peptide. And we have a whole slew of agents. The first ones to come out were these monoclonal antibodies that are a monthly injection. 3 of them are a monthly injection you give yourself at home to prevent headache. And then there's one that's a quarterly infusion. Our gentleman in the back, he's representing them. A quarterly infusion that you come into the hospital for to prevent headache. And what's great about these is that it's not another pill, side effects of another daily pill. And it's just a once a month shot to prevent headaches. So after all of these years, with one of the most disabling conditions worldwide, we finally have a specific preventative treatment. It just took forever. All right. But if you want something more natural, because some people were like, I don't want to be on a pharmaceutical. I want to try something, more natural for my migraines, which is fine. There is some decent-ish evidence for things like riboflavin, which is vitamin B2, magnesium, feverfew, CoQ10, melatonin. There's some in the literature, petadolix, which is from the butterbur root extract. Medical marijuana.
We don't usually prescribe that, but patients.
It comes up. I mean, this is more anecdotal. We've had patients who have tried it. But again, we try to do things more evidence-based.
And then these are just some examples of some of the devices. They all have brand names too, but devices, electrical kind of stimulation, trying to reset those pain pathways and, interrupt the signaling, go on the forehead, on the arm, on the neck to stimulate various nerves. So, these are just kind of some of the things that people have found to be helpful. And we do give information about this as well.
Yeah. We kind of already talked about this.
Yeah, and then we're going to actually go into more of the kind of cognitive behavioral theory, mindfulness, biofeedback. We'll go into that more later. And then how long do you give a preventative? So there was a study that looked at 771 people with high episodic or chronic migraine. And they found that 65.6% of patients responded at 12 weeks, 84.6% responded at 24 weeks. So general rule of thought is for an oral treatment, we would want to give that at least 3 months. And for these kind of monoclonal antibodies or those monthly injections, we'd want to give at least 3 months, but even up to 6 months, because we're seeing studies that the longer you stay on it, you respond a little bit better. Botox, we usually give at least 3 cycles of the injection.
So can I interject a little bit?
Yeah.
That being said, if you're, suffering obviously and having a lot of headache, I have no problem adding stuff along the way.
Correct.
Yeah. So patients will ask, well, then how do I know what's working? If we're starting multiple preventatives kind of simultaneously, that's true. We might not know then, is it this oral agent? Is it the Botox then versus the injectable then? But then I'm always of the mindset, well, do we care if you're feeling better? So it's kind of up to you and your preference, it gets to be tricky because, so I'm just going to throw that out there.
Totally agree. And then I think the last thing to talk about is prescribing advocacy. And, as Shirley had mentioned, I'm part of a patient advocacy training program that goes on every year. All of the meetings are virtual, and it includes the Miles for Migraine staff, along with the headache fellows for that year, along with lots and lots of patients who want to be part of this. How can I advocate for myself and others? Advocacy serves as a very powerful tool to address the needs and challenges faced by everybody living with these chronic conditions. helps break down stigma, encourages research into effective treatments, and ensures that individuals are going to receive the proper medical care. And, you know, this includes sharing personal stories, dispelling myths, and kind of educating the public. We've talked about creating an elevator pitch. If you're in an elevator with someone for a minute, what can you tell them? And they ask you about migraine. What can you tell them to try to get certain things across about this chronic condition or living with the chronic condition? And so if anyone is interested, you can go on the Miles for Migraine page. It's called the Act Now Advocacy. It's the Advocacy Connection Team, Act Now training program for fellows and patients. And we talk about stigma, creating that elevator pitch, access to healthcare, insurance concerns, and we all do an advocacy project, which can be anything that includes doing something for advocacy. We have some school teachers who said that what they want to do is try to bring more awareness of migraine into the schools with kids suffering from migraine. And so really and truly feeling empowered to advocate for yourself and to seek the care and support that you need and deserve. And that's kind of what advocacy is all about. Sorry.
Do we have time for questions?
Yeah,
Yeah.
absolutely.
Yeah. All right. Thank you, guys.
Yeah.
I don't even know what I'm supposed to do next. I'm going to let you take care of it.
Pre-training.
Thank you. Okay, well, that was a lot of information. Hopefully that was helpful for most of you. We will take questions actually after the next presentation, just so we could stay on time. Our next presenter, her name is Dr. Kirti Tumala. I hope I'm saying her last name correctly. She's the assistant professor of psychology and pain psychology here in the Department of Neurology. And she earned her bachelor's degree at the University of Michigan, her PhD in clinical psychology with a specialization in health psychology at Arizona State, and completed her postdoc fellowship at Rush University in Chicago, Illinois. Dr. Tumala is she's passionate about helping people understand how psychological factors like thoughts, emotions, and behaviors impact pain. Her clinical work focuses on teaching individuals behavioral techniques to improve migraine and other chronic pain conditions. Let's welcome her now.
Hi, everyone. All right, so hi, I'm Dr. Kirti Tumala, and I'm a pain psychologist. I work here at MCW in the Department of Neurology with our headache medicine team. And for some of you who might not be familiar with what a pain psychologist is, pain psychologists are just clinical psychologists, but we subspecialize in working with people who have chronic pain conditions. So yeah, that's who I am. And thank you, Shirley and Miles for Migraine, for inviting me to talk to you about the role of psychology in pain. So my goal today is I really thought about what would I talk about with people who are maybe really naive to the idea of pain psychology. So the first question is really, okay, what does psychology have to do with my pain? So that's really where we're going to start. We're going to talk about, this is one of the most important pieces of my work with my patients, is educating people about how psychological factors can affect our brain, our nervous system, which can then impact pain. When you have that understanding of how pain works, then the techniques we're going to talk about, everything from cognitive behavioral therapy, relaxation training, all of that makes more sense when we first understand how pain works and how psychological factors affect pain. So we'll start with that. Then if you're like, okay, I can kind of, maybe I see some of this, like, what do you want me to do about it? Then we're going to talk about some of the tools and techniques that you can use. And if you're still with me after that, you're like, okay, now I want to learn a little bit more. I'm going to end by sharing with you some resources that you can use to explore on your own, books, if you're into reading, websites that you can use, podcasts. I'm a big fan of podcasts. There are apps, lots of apps now. Or if you want to work with a pain provider, like a pain therapist, how do you go about finding one? Okay. So let's start with, what does psychology have to do with my pain? The reason, again, that this is really important is because there's a lot of studies done looking at what does pain education, pain science education, do for people. Studies have shown that when people understand their pain and understand all the different factors that can affect their pain, it improves their understanding, but studies have actually also shown that it helps reduce, even before we work on the tools and techniques, even just that basic understanding can help reduce pain intensity. It reduces poor coping, like the ways that we can think that are unhelpful, avoidance cycles. It can help improve day-to-day functioning. It can help reduce disability. And it also increases something that Dr. Collins brought up, which is self-efficacy. Self-efficacy is our belief in our ability to cope with something difficult. In this case, it would be coping with pain. We often feel like, when we're dependent on a provider for helping us with pain, that it feels like somebody else has all the control. I have to wait for an appointment. It's going to take another 6 months. Somebody else has to give me suggestions. There's not much that I can do for myself. That can be really disempowering. And when people know more about their pain, it's actually been shown to help increase their sense of confidence in their ability to do things for themselves, things that can be helpful with the pain. So let's start with just a basic definition of what is pain. Okay? So this is the definition of pain by the International Association for the Study of Pain, which is that pain is an unpleasant sensory and emotional experience. When we often think about pain, we focus on, if you go to the doctor and they're like, tell me about your pain, we focus on the sensory aspect of it. It's sharp, it's shooting, it's dull, it's achy, it's tingling. Oh yeah, sorry. Are you guys able to hear me okay? Okay, good. Yeah, so we focus on the sensory aspect of pain. But by definition, when you're in pain, there's also an emotional experience to it. Maybe it's just, something as mild as a little bit of annoyance. Maybe it's something more like worry or stress about, how am I going to deal with this? How am I going to get through this? Pain is, for everyone, always both a sensory experience and an emotional experience. So the next thing that I want to talk about is this idea that all pain is actually created in the brain. And I'll tell you a little bit about why that matters in a second, but just bear with me through some of the science of this. All pain that we feel, whether that's a backache, a sprained ankle, stubbing your toe against something, a stomach ache, muscle fatigue, neck pain, shoulder pain, headaches, all pain is actually created in the brain. So for example, let's say that you sprain your ankle and you're like, but I can feel the pain is in my ankle. I can feel it right there. What's actually happening is that the neurons in your ankle are carrying that information up through your nervous system. You guys have all seen pictures of, I'm sure, nervous systems before, a brain and all the nerves that are coming out from it. Those nerves are going to take that information up through your spine and into your brain, and your brain is going to process that information and generate pain. So pain is always generated in the brain, whether, again, you get a paper cut or you sprain an ankle or you break something, pain is always in our brain. So you may be asking, well, why does that matter? Why does it matter that my pain is in my brain? It's because in the past few decades, we've really come to understand that the way that your brain puts together pain information is really complicated and involves a lot more factors than we thought before. So in the past, we used to think that the way that your brain decides how much pain to create is the nerves in your body will take that information up to your brain. We have something called the somatosensory cortex. That's a sensory part of the brain. That part of the brain will register things like, what kind of sensations are you experiencing? How intense is this pain? Where is this pain coming from? So location, intensity, sensations. But that really was the main part of the brain that was involved in processing pain. Just the sensory part and the motor cortex. But what we're learning now is that it's actually a lot more complicated than that. There are lots of different parts of your brain that are involved in processing pain, including the emotion centers of your brain. Okay. So I'm not going to talk about all the different emotion centers, but I'm going to use my fist as an example. Can you guys see my fist? Okay. So I want you to imagine that my arm right here is your spinal cord, and that my fist is the brain. Okay. And deep inside our brain, we have something called the limbic system. And part of the limbic system is an organ called the amygdala. That is the fear center of the brain. Okay. The fear center of the brain is processing, pain is meant to be a danger signal to the brain. It's meant to let your brain know that something's wrong, pay attention. And it processes things like fight or flight, emotional responses to pain. And that part of the brain also receives pain information. It's involved in helping the brain decide, what do I do with all this pain information? Okay. So we have the emotional or the fear center of the brain. Another part of the brain that's involved is, now my fingers that are covering over it, that's the cortex. That's the squishy, squiggly parts of the brain that you see in pictures of the brain. I want you to picture that roughly right here is something called the prefrontal cortex. That's the thinking, the higher order thinking part of the brain where we're processing things like paying attention, decision-making, planning. If you're cooking a recipe, you're thinking through, okay, I've got to do this first and that next. You're thinking through your day, you're trying to figure out, okay, I have this headache, but okay, what else do I have to do for the rest of the day? So that part of the brain is helping you decide, planning, judgment, assessing a situation, taking into account, what do I have to deal with? How am I going to deal with it? What's going to be my plan of action? That part of the brain is also involved in processing pain. Okay. So it's not just as simple as X amount of information goes into your brain, and because of whatever sensory information, it's always going to produce Y amount of pain. There are different parts of your brain that are involved in helping your brain assess what's going on and how much pain do we generate. Okay. So let's talk a little bit about what are the psychological factors that influence how pain is felt. We already talked about the sensory input, physical sensations, pain intensity, location of the pain, emotions. So there are studies showing that when we feel certain emotions, and again, these are all perfectly normal emotions to feel when you're in pain, but emotions play a role. I want you to picture that there's a volume dial in your brain, like a car stereo volume dial. And some of these factors can either help increase that volume dial or help it turn down. Okay. So emotions like fear, stress, anxiety, irritability, anger, frustration, feeling sad, all of these emotions are all also processed in that same fear center of the brain. Okay. So we talked about how pain, the fear center of the brain processes pain information. It's also processing all the stress that you're experiencing in life, all the emotions you're experiencing in life, like whether you had a fight with your partner or you're running late or you're stuck in traffic. It's the same part of the brain that's processing it. Okay. And when our emotions are really high, our brain decides to turn the volume up on pain a little bit. Okay. Beliefs about pain, catastrophizing, like, again, a normal feeling for all of us to have when we're in pain is, I can't handle this. This is too much right now. Oh, this is going to ruin my day. Thoughts like that put your brain on high alert. It sends that fear center of the brain into alarm mode. Okay. Other things that we found helps influence how our brain will process pain information are things like that feeling of pressure, self-criticism, like, how many of us have thought, oh, if I just gotten more organized yesterday, I should have known better. I should have planned better. I should have gotten all the should statements. I should have done X, Y, and Z. If I had just been better about this, somehow this is my fault. I'm letting people down. These are all that feelings of pressure. What does the brain do with that feeling of pressure? It interprets that as threat. This is dangerous. And it sets that danger, the fear part of the brain into that alarm mode. We're not okay, alarm, 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 okay? So that can turn the volume up. perceiving threat. So depending on how threatening that pain feels, your brain is also going to decide how much volume to give that pain. So for example, let's say that you're a runner, you go running regularly, and once in a while you get a leg cramp. It's not a big deal. It comes, it goes away in a couple of minutes. You kind of know that it's not a big deal. Who cares? But let's say that you've never experienced a leg cramp before. For the first time in your life, you just get this really sharp shooting pain. That's going to be really bizarre and threatening. Like, why is this happening? Why is, what's going on in my body? And that pain that feels more threatening is going to have a louder volume than the one that we can assess as, yep, been there before, not a big deal. Okay. Oh, I forgot to mention in the last slide that another part of our brain that's actually involved in processing pain is a part of the brain called the hippocampus, which is the memory center of the brain. The memory center of the brain is really important because it helps us decide, have I experienced this before? Do I know this? How have I dealt with it before? Was it fine? Was it not fine? Again, same thing with experience with, let's say, you get a leg cramp. You've had that before, not a big deal. It helps your brain understand that, you know what, we've been here before, it's okay. But let's say that the last time you smelled cigarette smoke, you got a really bad migraine. And the next time you start smelling cigarette smoke, the memory center of the brain is going to put you on high alert of, it was bad last time. Be cautious, it got really bad last time, this could be bad. Okay. So this is just an example of how, again, the way that your brain decides how much pain to produce is not always a black and white decision of X amount of physical factors are going on, therefore there's always going to be a Y amount of pain. Your brain is actually making a really subjective decision based on a lot of different factors, including psychological factors on how much pain to produce. Okay. So let's talk a little bit more about the pain fear cycle. Okay. So I talked about this example of our brain. Okay. Again, my thumb is the fear center of the brain. My fingers covering it are the higher order thinking part of the brain. Okay. So these two parts of the brain actually talk to each other. Our different brain parts are communicating with each other. When we're stressed, when we're overwhelmed, the thinking part of the brain says to the fear center of the brain, actually, the situation is okay. You can turn off that fear, that alarm signal that's going off. So let's say that you're kind of, again, you get that leg cramp and that fear center of the brain is firing off saying, alarm, 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 pain, pain, pain. The thinking part of the brain comes in and says, nope, this one's okay. We've been there before, not a big deal. We've dealt with this. The planning judgment part of the brain is saying, yep, this is something we can deal with, not a big deal. And it actually communicates back to the fear center of the brain to say, let's turn off that fear response. You don't have to keep firing off saying alarm, alarm, alarm. Okay. Now what happens? Yeah, that's the fear center of the brain. Now what happens when we have pain plus stress about the pain, fear, frustration? Gosh, when am I going to be able to get in for my next appointment? I only have this many pills left. How am I going to manage all of this? I've got so many things I need to get done today. All of that heightened emotion really puts that fear center of the brain into really high alarm. So the alarm system is going alert, 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 alert. And you metaphorically, the thinking part of the brain goes offline or it becomes disabled. It's not able to communicate back with the fear center to say, hey, we're going to be okay. Let's turn that signal off. It's gone offline. The fear center has taken over. Sometimes we call this amygdala hijacking because the fear center of the brain hijacks the brain. And that really amplifies the pain signal. Okay. So what we're going to work on in pain psychology is how do we bring that higher order thinking part of the brain back online so that it can communicate back to the fear center of the brain to say, it's okay. We're going to be able to get through this. You don't have to fire the alarm so loud. And that helps the brain turn down the volume on pain. Okay. We also have studies showing that over time, pain can actually get worse. Psychological factors can actually make the pain process worse. Okay. So anytime our nervous system and our brains are plastic, meaning that they evolve over time. When let's say, for example, that you're learning how to play the piano or you're learning a new language, The first few times you do it, it's really awkward and clunky. You're not very good at it. But with enough practice, it becomes more automatic. You get better at it. It's the same thing with pain, unfortunately. When this pain-fear cycle replays over and over and over again, especially in chronic pain, unfortunately, we just get better at feeling pain. Okay, so this process is called sensitization. Over time, that flight or flight mode becomes activated more easily. The nervous system gets really a lot more efficient at producing pain. We become a lot more sensitive to triggers or anything that can cause pain. So pain sensitivity can actually go down over time. And so psychological factors play a role in not just how we feel pain in the moment, but also how our pain can unfold over time. What happens to our pain process over time. Okay. So as pain psychologists, we always say that pain is not just biological, it's biopsychosocial, meaning when we think about pain, we often think of it in this biomedical model. It's, we have to address structural issues, injury, inflammation, the disease, the neurochemistry, which are all extremely important part of this process, part of treating pain. But pain lives in the middle of those biomedical factors, but also psychosocial factors. Our emotions, our beliefs, our coping strategies, our relationships, financial pressures, all of these things are also having an impact on pain. So really the best way to treat pain is not just through the biomedical part of it, but also addressing the psychosocial part of it. Okay. That's a much more comprehensive way of thinking about our pain, understanding our pain, and also treating it. Okay. So now if you're still with me, you might be asking, okay, thanks for all that information, but now what do I do about it? Okay. So we talked about this volume dial in the brain of how there's a little volume dial in the brain that can turn the volume up. So we can also use the same set of tools, our thoughts, our emotions, our nervous system, to turn the volume down. Okay. You might have heard of cognitive behavioral therapy. You've heard about mindfulness meditation. You've heard about relaxation strategies. This is kind of what we're going after in these different therapies, where we're going to go after thoughts, we're going to go after emotions, and we're going to work on regulating our nervous system. So I'm going to give you a brief overview of what that might look like, some strategies that you can take home today. So let's start with our thoughts. I often tell people that our goal with working with our thoughts is to lower the stakes. Again, you're targeting the brain. You're targeting that fear center of the brain that's firing off saying, danger, 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 danger. Something's not okay. I'm not okay. We're working on calming down that fear center of the brain and trying to help it feel safe. So our goal is really going after the brain. Okay. So we do that. I mean, unfortunately, we have no way of, putting our hand into our brain and telling that fear center to stop. Our only access to our brain is really through our thoughts, as well as emotions and nervous system, but we'll start with the thoughts. So let's talk about how we might work with some classic thoughts that all of us have when we're in pain. I can't handle this pain. My day is ruined. There's nothing wrong with thinking like this. This is a very normal thought to have. But the problem is that thoughts like this can put, again, our brain into that alarm mode, okay? So I often encourage people to try to look at a situation that feels threatening through a lens of safety, okay? So maybe trying something like, yeah, this is a lot right now, but I've gotten through days like this before. I can get through today, okay? The idea here is not to go from negative thinking to positive thinking. If you're somebody who likes positive thinking, if you're able to take a bad situation and turn it into something positive, good for you. That is not me. I am not a fan of that. Often situations are just not positive, and it's not good to gaslight yourself into, thinking that everything has to be positive all the time. Our goal is not to think positive. Our goal is to turn the volume down, lower the stakes, okay? Let's try another one. I'm a bad parent, spouse, employee, friend. I'm a burden to other people. Again, a very common thought, feeling, place that we've all been. Trying something like, yeah, it sucks that I can't show up for other people how I'd like. I always tell people that start with something validating. There's nothing worse than talking to somebody about how bad you're feeling and for them to say, you're fine. It's, just, you'll be fine. Don't worry about it. There's nothing worse than that kind of invalidation. And we're not trying to be invalidating of ourselves. So you're not trying to tell yourself, you're just overthinking this. You're fine. Get over it. That's not the language we're going for. We're going for empathy, validation. Always start with empathy and validation. Yeah, it sucks that I can't show up for other people how I'd like. But the difference here is that we're going from really global statements like, I'm a bad parent, I'm a bad spouse, I'm a bad employee, to making it something a little bit more contained. I'm having a bad moment right now. Today, I don't feel so good about how I'm showing up. Going from words like burden, which can again be really threatening, to, yeah, you know what, I'm doing the best that I can, and I have to give myself a little bit of grace. Yeah. So this is again, we're not going for a Pollyanna, look at everything through a positive lens perspective. We're just trying to turn the volume down. Other example of, I should have gotten better by now. I feel like a failure when I'm sick. Again, those should statements are there with us all the time. And somehow this is my fault. I should have done better if I just planned better, if I'd gotten more done yesterday. Maybe today would have been, I should have known that this was coming. In those moments, just kind of taking a step back and saying to yourself, okay, maybe I'm putting a lot of pressure on myself. I'm working on getting better. That takes time. My pain doesn't make me a failure. Because again, words like I should have, all the should statements, words like failure, that can be really threatening to the brain. Your brain is listening. The fear center of your brain is listening to the words that you're thinking. So we're just reframing it from more of a safe lens. So I often tell people that, imagine that you're putting on a safety lens. Can you look at the same thought and just remind yourself that there is still some safety there? Because we really just want the fear center of the brain to calm down, the thinking part of the brain to come back online and help regulate our feelings. Okay. I'll just go through a couple more examples. Nothing is working for my pain. I'm never going to get better. Again, starting with validation. Yeah, I feel really defeated right now. This is taking longer than I thought, but I'm going to take it one step at a time, and I'm going to keep working on healing. The difference, again, there is you're not going from something completely negative to completely positive. You're focusing on validation, empathy, and saying something encouraging to your brain. Okay, I'm going to keep going. I'm going to take this one day at a time. Okay. And that's just not to just make you feel better. That again I often tell patients that imagine that little fear center in your brain is like a 5-year-old, because it is a really primitive part of our brain. And your job is to babysit that 5-year-old. It doesn't always respond to, well, you just need to stop crying, or you just need to get over it. It responds to comfort. It responds to validation. It responds to feeling safe. So that's your job, is to help babysit that 5-year-old in your brain. Another thought like, I can feel my headache getting worse. I have to get through this dinner, event, talk, meeting, activity, kids' basketball game, whatever it is. What if it gets worse? I'm trapped. Trying something like, yeah, I really don't like when this happens, but it's going to be okay. This is a temporary situation. This event will end, and then I can go relax. I'm not trapped here forever. So again, you're just kind of trying to calm that fear center of the brain and remind it that this is not a forever. This is not a overwhelming situation. Can we kind of look at it through a lens of safety? Okay. So then we're going to work, we can also work on our emotions. So positive emotions can help our brain feel safe. If you think about, again, I explained how that fear center of the brain is activated because pain is meant to signal to our brain that you're in danger. So if you're touching a hot stove, the pain lets you know that you need to move your hand away as quickly as possible before you burn yourself. If you have sprained your ankle, the pain lets you know you need to get up, stay off of that ankle, because if you keep walking on it, it's going to get worse. So pain lets our brain know that something is wrong. We might be in danger. That's why the danger center of the fear center of the brain is firing. And it cues us to say something might not be right. But the problem with chronic pain is that our brain is still chronically in that fear mode. And if you truly were in danger, like let's say that you're being chased after by a lion, you're not going to say, okay, while I'm running away, I'm also going to stop and smell these roses real quick, right? So positive emotions can actually cue to your brain that I must be safe because I'm also experiencing positive emotions. So positive emotions are a way of kind of hacking into your brain and reminding your brain that you are safe. And we're not going for really big positive emotions here, like getting excited about something, experiencing, joy and euphoria. We're really aiming for what we call low activation positive emotions. Things like feeling calm, just feeling kind of a moment of feeling satisfied, content, being curious or interested in something. Again, if you're in danger, you're probably not going to slow down and be interested in something. Moments of being grateful. These are not things that have to last a long time. You don't have to experience gratitude for hours. You just need little brief moments of positive emotions. And same thing with physical positive sensations. When you can kind of zone in on a part of your body that maybe feels safe or pleasant, that can help cue your brain that you're safe. So here are some examples. I always tell patients that when I bring up positive emotions, people start saying, okay, maybe I should plan a date night. Maybe I need to plan a trip. Maybe I need to plan something. Anytime you're thinking about adding something to your plate, that's not going to be sustainable. It's probably just going to add more stress. It's better to find positive emotions within things that already exist in your environment. You're just going to try to look at it differently or experience it differently. So for example, sitting by a window and maybe feeling the sunshine on your skin. If you like kind of watching birds, looking outside, seeing, watching the trees. If you're in the shower, even just for a brief moment, let's say a headache is coming on, you're in the shower, just kind of noticing the warmth of the water on your skin, that pleasant sensation, for even just briefly can cue your brain that, okay, I don't need to go into that alarm mode. For some people, that sensation of breathing in and out can be pleasant. That's accessible. It's always with you. Stretching, if you find that pleasant. Often, when we're drinking our cup of coffee in the morning, we're also scrolling, checking emails, doing other things. It can be something as simple as sitting down and saying, okay, I'm really going to spend 30 seconds savoring this cup of coffee. Is savoring that cup of coffee for 30 seconds going to change everything about your migraine? Absolutely not. But it's a brief moment of letting the brain know that there is safety here. So if you're planning on turning that volume up, you don't have to, we're safe. Okay. Being curious or interested in things in your environment, even just, even if you're sitting there kind of feeling, not great, seeing if you can just watch the dogs play, people watching, also self-compassion and gratitude. That doesn't mean that, in the midst of a bad headache, you need to be grateful. It's just kind of thinking about your life and maybe even just finding something small to just have a moment of gratitude. It could be something as simple as, yeah, I didn't get a lot of things done that I wanted to get done, but I survived a really bad day. Good job, me. I got through today. It's just like a moment of gratitude. Because again, we're focusing on sending safety signals to the brain. Taking pride in small accomplishments. I can't tell you how many of my headache patients talk about how bad they feel for the fact that the laundry's not done, the house is not clean, they can't get to the vacuuming. And it's always about what is still left to do. And I often tell people, give the brain a little bit of a dopamine boost. When you take a moment to take pride in the fact that, I got up today and I got X or Y done. That was hard to do when I had a headache, but I got that done. And I'm not just saying that to kind of, just appreciate yourself no matter what, but it's a way of kind of giving your brain that dopamine boost. Okay. And then regulating our nervous system. I think we're doing a mindfulness exercise later today, mindfulness meditation, relaxation exercises. There's a lot of evidence behind things like progressive muscle relaxation, diaphragmatic breathing, body scan meditation. We're not going to go into all of these, but these are relaxation training exercises that have been shown to help regulate our nervous system. Okay. When our nervous system is more regulated, again, it becomes harder for that fear alarm system in our brain to go off. If you're not somebody who's like, I don't like meditating, I don't like doing relaxation exercises, find something that you find relaxing. For some people, listening to music, especially maybe nature sounds, doing art therapy, coloring books. There's also a lot of research behind hypnosis, and hypnosis isn't what you might think of as that crowd hypnosis work where somebody is making you think that you can, act like a monkey or whatever. That's not that kind of hypnosis. This is clinical hypnosis, and there's a lot of evidence behind hypnosis for sleep as well as for pain. And it's really just like a deep state of relaxation. You would have to find somebody who's a certified hypnosis teacher. Usually they are a trained mental health professional. And it's achieving a deep state of relaxation and working from that place. It's really not, brainwashing you into thinking something that's not true. Biofeedback training. And again, finding a biofeedback professional who can, and actually there are apps now that I'll talk about to do biofeedback specifically for migraines at home. And it's a way of using feedback about your body through a visual screen. So like watching what your heart rate is doing or watching what your breathing is doing and using that information to help regulate the sensations in your body. Okay. So let me see how we're doing on time. Okay. So the key really here is with behavioral techniques, which is different than maybe taking abortive medications or getting procedures or any of that, is that we don't have a direct access to the brain. Behavioral techniques don't work right away. Consistency is what's going to be key. You're going to have, even if you start practicing these techniques, you will have good days and bad days, but sticking with it and thinking of it as we're trying to unlearn, we're trying to teach the brain to not do certain things that it's gotten used to, like certain types of thought patterns, emotional reactivity, nervous system responses, and we're teaching our brain a new language. We wouldn't expect ourselves to start speaking a new language right away. It takes practice, and you're doing the same thing with these behavioral techniques. You're teaching your brain a whole new language. Okay. So if you're still interested and you're like, okay, maybe I could look into this a little bit more, I would start by trying out some books. I think these slides will be available to you guys after, so you don't have to write it all down, but these are 3 of my favorite books for workbooks for starting to learn more about this and techniques that can be useful. Okay. There are also lots of mobile health apps that are available now. There's Control M, which is a migraine specific behavioral health app. Curable is probably one of my favorites. That's the one that most of my patients say is actually really good in terms of its interface and the type of techniques it offers. That one is unfortunately a paid one. It's not a free one. Pathways is also similar. It's a paid app, but I've heard really good things about it. Insight Timer is a meditation app. They have thousands and thousands and thousands of meditations available, and they're all free. University of California, Los Angeles, UCLA has their own app called UCLA Mindful. All of their mindfulness recordings are free. And there is a new app called Juba for migraines and headaches, and it's a biofeedback app for migraines. It uses the camera function on your phone to track your breathing rate and to give you feedback. So I mentioned that I'm a big fan of podcasts. I think it's a great way to learn about pain, about why psychological factors might be important in your pain journey. So these are a few that I really like: the Healing Pain podcast, Tell Me About Your Pain, Spotlight on Migraine, and Pain Reframed. And you can even go into these podcasts and just type in psychology or CBT or mindfulness, and it'll pull up more information. Okay, here's just some websites. I won't go through all of these. But places where there's a free online behavioral health, if you can't find a pain psychologist or a pain provider to work with, or if that's outside of your resources right now, there are free online guides available. And lastly, I just want to touch on, if you do decide that you want to work with a behavioral health provider who focuses on pain, how do you go about doing that? The first is just going into Google and typing in psychology today for psychology today chronic pain therapist. I included a link as well. And then you can look for people within your area who list pain psychology or working with chronic pain as one of their subspecialties. Okay. The interventions that I would recommend looking out for are evidence-based interventions. Evidence-based interventions like cognitive behavioral therapy for chronic pain, ACT, which is acceptance and commitment therapy for chronic pain. There's a newer intervention that has very, very strong evidence behind it, which is pain reprocessing therapy, and of course, mindfulness for chronic pain. Okay. Now, a lot of people are going to list chronic pain as one of their subspecialties, but I would really ask your provider some questions like, how did you get trained in this? You don't want work with someone who just kind of puts it up there as one of their 1,000 other subspecialties, but asking them, have you done any training in this? Are you self-taught? Did you go to a seminar? Did you take courses on this? What's your background in working with people who have chronic pain? There's nothing worse than feeling like you have to educate your provider about pain. And then lastly, you should look out for things like a good pain provider, so a pain psychologist or a pain therapist, should teach you about how psychological factors affect the brain. Really start with that education. They should have that knowledge. They should also teach you specific tools and techniques on how to work with pain thoughts, emotions, behaviors. So if you're going to therapy and they're just, you're just kind of talking about general things about life and they're never really talking about what to do about the pain part, I would consider thinking about, well, this person might not have the most amount of training or knowledge about working with chronic pain. A good pain therapist should also give you homework to do. These are, again, like I said, techniques that are not going to be built overnight. It takes consistency. So if you're just talking to someone week to week, but they're never giving you any homework to do, that's probably not going to be effective. You should be working on homework between sessions so that you're actually getting something out of it. And lastly, I'll just leave you with this poem. And thank you all for letting me talk to you about pain psychology. And yeah, it was great.
Okay, fabulous, right? Okay, we're going to take a little break. Before we do, we're going to do a little mindful pause. So let's take a moment to just close your eyes and take a deep breath in through your belly, and then just relax out through the mouth. And just do that one more time. Deep breath in through the nose, belly expands, exhale, relax. And last time, inhale and exhale. Mindful sigh. And when you're ready, open your eyes. So I think Dr. Famula's talk was amazing. And so I do think that I'm a former mindfulness teacher and yoga therapist. And I do think that's what really helped me get through my journey. And I hope that you will also go to our website, Miles for Migraine. If you go to programs, there's a drop-down mindfulness section. We offer every other Thursday free programming. And we have a YouTube channel filled with meditations and yoga. And so please check it out. We're going to take a short break now till 11:20. If you came in late and you did not check in, come and please see me. The agenda is going to go up right now. If you can you put it up on the screen? And then you can take a picture of it if you, because I didn't have any paper agendas today, I apologize. And if you haven't done the pre-survey, please come see me. And at the end of the day, I just want to mention that we're going to be giving away a free pair of TheraSpecs and also a green light therapy light, which is really great for people who have migraine. So please go, and if you need to take a break and you want a quiet place, if you go out to the left, there's a sofa there, you can go lie down. It's kind of dark. How's the lighting in here? Is it okay? Okay, good. It's a little dark, but we're used to being in the dark, right? So please get up, stretch, and please come back at 11:20. Thank you. Oh, you have to do it.
No, I have to be up here.
Okay, welcome back. And we're going to get time to chat at lunch, and we're going to go into small groups right after the next presentation. So a couple of other things. If you need to take care of yourself at any time, please just leave and go outside, walk outside if you think that's going to help you. Go lie down on the sofa. I know the lighting is challenging. I know it's dark. So if anybody feels like it's too dark, I was going to suggest we make that side of the room brighter, but it's, we all have different needs. That's for sure. I know what that's like, myself included. So what we're going to do next is I'm going to introduce our next speaker. And I just want to say that during lunch, we're going to actually have a working lunch. So we're going to do the Q&As for our morning speakers. And we do have a lot of questions. I ask that if they have any questions in this room, if I'm going to put a pad of paper up here, if you can write down your questions, because we won't have, everybody has questions. This is really important information. So I'm going to ask that you write down your questions and give them to me. And then, because sometimes we get the same question twice, and then we have questions in the chat. So we're going to try to get to as many questions as we can. Okay, so our next speaker is Sarah Arndt, and she's a patient advocate, and she's lived with migraines since infancy, but wasn't diagnosed until her mid-30s. Sound familiar? When it became so debilitating, she lost her job and spent 2.5 years in bed. Sarah is living proof that a holistic approach can completely transform your health, and now she professionally serves as a certified health coach, helping others manage migraine using a science and ancestral-based approach. Sarah is passionate about migraine advocacy and hopes to empower others to take their health into their own hands and become their own best advocate. Welcome, Sarah. Okay, do you know how to change the slides?
Just tap it
Yeah,
quicker.
let me ask them to show.
Yeah, you can use the keyboard, the mouse.
Just like right?
Yes.
Perfect,
Or
I'll
you can
do
use
that.
this if you want.
Okay, thank you. Is this on? Yes, it is. Thank you. Thank you for that introduction. Like Shirley said, my name is Sarah Arndt. I am a patient advocate and a provider in the sense that I am a certified health coach who practices from a holistic approach, because that's what's really helped me as a patient. And I'm really excited to have this conversation with you all today, because for many, many years, I didn't even realize that I had migraine. And I now have been diagnosed with vestibular migraine. I also have chronic migraine, meaning I experience some level of symptoms essentially every day, and that fluctuates. I'm sure many can attest to that. But in 2019, I was completely debilitated. I lost my job. I spent nearly 2.5 years in bed. I thought my life was over, and I'm living proof that healing is possible. And you couldn't have paid me $1 million to tell me I would be standing here in front of a group of all of you, presenting, talking about how I've healed from migraine and I'm continuing to heal. And today we're talking about how to master your migraine elevator pitch, and in a way share your story with others in an articulate and concise way, so that others can understand truly what we're experiencing, because migraine is an invisible disease, right? Like my pain today is probably, I would say, or my symptoms, I would say like a 3 or 4 out of 10, but I look fine, right? I look completely fine. So to colleagues, to friends, to family, we look fine on the outside, and it can be really hard for people to understand what we're really experiencing on the inside. And mastering your migraine elevator pitch and sharing your story with others is a really powerful way to self-advocate. So let's get into it. So like I said, it's a concise, compelling way to introduce yourself and your topic in a short time frame, and it's a form of self-advocacy. So when discussing migraine, it's essential to grab your audience's attention and convey the significance quickly. I participate in many different advocacy initiatives, and one that I'm participating in that I just learned Shirley will be with me at on Monday is Headache on the Hill. I'm flying to DC on Monday morning to advocate for headache policy, and going to Capitol Hill on Tuesday morning to talk to congressional offices about legislation for migraine. And it's my first time doing it in person. I've done it for 4 years, but it's my first time in person. I'm so excited. And in my experience doing that event specifically, you know, legislatures, people who work in politics, they're very busy, right? And I've had colleagues who have shared their story and it's gone on for like 5 or 10 minutes. And by 5 minutes, I would say by 2 minutes, we start to lose people, right? So that concise piece, I think, is really important because we want to get across what we want to convey and we don't want to lose people. So we want to grab their attention and get across the significance of this issue quickly. So creating an elevator speech to disclose information about your migraine to friends, family, colleagues, anyone really can be a helpful way to communicate your condition effectively. And it's an informational statement that can be delivered in the time it takes to ride an elevator. So typically 30 seconds to 2 minutes, not 5 or 10 minutes, although there might be situations where having a longer conversation with like a family member or a friend might be appropriate, of course, as well. So why do you need an elevator pitch? We all know that migraine is a complex disease. It's not just a headache. We talked about, Dr. Collins talked about stigma and how there's such a huge stigma with migraine, right? We just talked about how it's an invisible condition. I look fine. And we know that it's not just that, it's so much bigger than that. And migraine receives very little research comparatively to disease burden. In fact, I think it's the most or the least funded comparatively to disease burden, if I remember correctly. And we need to change this. So how do we do this? We advocate. We reframe migraine and headache diseases to increase diagnosis, research, and reduce insurance barriers. And of course, the goal is always to find a cure. And self-advocacy is the way to do that. So step one, and I think you all got a handout for this. So if you haven't pulled that out yet, if you haven't grabbed one, feel free to stand up and go grab one now. But this will go along handy with our conversation here today. So step one is starting with a greeting, and begin by addressing the person you're speaking with in a friendly and open manner. And I just want to say that this can be hard because when we are feeling frustrated about how we're feeling, maybe a family member or friend that we want to share this with hasn't listened to us before, we might have felt unheard in the past. It can be really easy to get defensive, to get frustrated. So we want to be, of course, friendly and open when we are starting our conversation. And step two, we want to talk about what is the condition that we live with. Clearly mention your diagnosis. You have migraine, you have a headache disorder, maybe the specific type of migraine, vestibular migraine in my case, chronic migraine in my case. So for example, I want to speak with you about something important. I live with chronic migraine, or I live with vestibular migraine. And then step three, what is migraine? Provide a brief, simple explanation of what migraine is. And this is going to look different for everybody, of course, but you might say something like migraine is a neurological condition that causes severe headaches and a range of other symptoms. You might go into specific symptoms that you experience, or you might wait a little bit to get into your personal experience. Here, so step 4 is your personal experience. Explain how it affects you personally. What symptoms specifically you experience. And this is kind of where we also can tie in that emotional aspect of migraine, how it affects us emotionally. It can be really difficult to even express that we live with migraine, because living with migraine is an emotional experience, right? So for me, you could say migraine often includes intense headaches, nausea, sensitivity to light and sound. It can be very debilitating. I might say that I experience symptoms of dizziness. I have moments where I am completely debilitated in bed and can't move for a series of hours, or maybe even an entire day or a half of a day. So this is where you can really share what you personally have experienced in your condition. And then triggers. So this is something that can be difficult for other people to understand, because it's like, how could a light being on possibly be a trigger for you? But if you know what triggers your attacks, share some of them to help others understand how they can support you. So for example, I walked into this room, the lights were dimmed. I was so excited. I brought my hat just in case, because I have severe light sensitivity. I have these glasses with me just in case I need to wear them, which I don't today, which is great. But just in case I need them, I have them with me at all times. But sometimes it's hard for people to understand that these simple things that exist in everyday life are actually triggers for our attacks. And so share what it is that actually triggers you. And that might be food, stress, a lack of sleep, certainly is for me. And help others understand what it is that triggers your migraine attacks. And that's going to be an opportunity for them to, of course, to understand your situation and better support you. So with that, when we express our needs, that's an opportunity for people to understand how to support us. So let your family and friends know what you need from them. And so this might include support or taking specific actions, like getting my med bag or turning down the lights or getting an ice pack. For instance, during a migraine attack, I may need quiet and a dark room to rest. Your understanding and support means a lot to me. And I made a note here to say that when we're asking someone what we need, it can be really easy to be frustrated because we're experiencing debilitating pain and symptoms, right? So the caveat that I like to add here is that I like to share that, like, I'm not upset with you. I'm not mad. It's that I'm upset about the situation. It's frustrating to live with migraine, right? That emotional component of living with migraine, it's frustrating. And that's why I might be behaving this way or talking in this tone. I'm not upset with you. So yeah, explaining what your needs are can be really, really helpful for other people to be able to understand what you're going through and how they can support you. Oftentimes people want to help, but when they don't understand what migraine is, they might not know how to support you, and really articulating specifically how you like to be supported is a great way for your loved ones, your family member, friends, even your colleagues to be able to support you in a very specific way. So you can also offer resources. So there's tons of resources available. Of course, Miles for Migraine has a ton of amazing resources on their website. So you could say something like, if you'd like to learn more about migraine, there are many reputable websites and articles that can provide additional information. And there will be a resource page that will be in a follow-up email that you'll receive after this program as some examples that you could share with people when you're sharing your elevator pitch. And then of course you want to thank your listeners, thank them, express gratitude for their willingness to listen and to learn about your condition, and for being supportive. That means a lot to you. there's so many people in our world that are unwilling to listen and be supportive. And when we get a listening ear, we want to be able to thank them, right? And show appreciation for their willingness to listen and to care. And then practice. You can practice with someone who lives with migraine. Maybe the two of you could practice together. I think we're going to do a little bit of that today. And practice is important so that you can deliver it confidently and clearly. And you can also refine it based on your audience and your audience responses and questions. So of course, my conversation with you today is going to look different than a conversation I might have with a colleague. It might look different than a conversation I'm going to have with a friend. And it certainly will look different than a conversation I'm going to have with Senator Tammy Baldwin and her team on Tuesday when I meet with them, right? You're going to need to craft your elevator pitch based on your audience, of course. So be open to questions and further discussion, and let whoever is listening know that you're open to answering any questions that they might have or discussing your migraine journey further with them. And the key, like we talked about, to an effective elevator speech is brevity or conciseness and clarity. You want to convey the most important information in a concise and understandable way, making it easier for people to support and empathize with you. And if you are new to migraine, you can practice your general pitch to a friend, family member, coworker, or boss. And if you're an expert, you can practice rebuttals such as, well, I get headaches too. Or, just Tylenol works for me. I can't believe that doesn't work for you, right? Things that we've all heard a million times, just drink some water, right? You just have too much stress. Oh, okay, great, thank you. That's really helpful. We want to practice rebuttals to that, of course, as well. So I think that Shirley is going to, yeah. So Shirley is, yeah, so we're going to practice.
Right.
Yeah.
Okay. So we're going to do a little practice so you can get an idea. Now you might say to yourself right now, like, why are we doing this? But this is so weird. But guess what? I've gone to Headache on the Hill. This will be my 9th year. And there are all these new people going this year, and they have to be able to tell their story to their member of Congress in less than 2 minutes. And you can't go on long-winded. You've got to be precisely get your point across. And I remember the first time I had to do this, I was so nervous. I had no idea what to say. Meanwhile, I mean, I could do it in my sleep now, but it would be really important for you to pick a scenario. It doesn't have to be Headache on the Hill. Is anybody going to Headache on the Hill here? Okay. Anyway, next year you'll get a virtual opportunity, which I think it's going to be in the fall. So if you go to just write this down, Alliance for Headache Disorders Advocacy. If you go to their website, you can register for their newsletter and you'll get all the information. It's something that we all need to do.
Or AHDA.
Well, if you type in HDA, it won't come up.
Or Headache on the Hill.
Yeah,
It's the
if you
very
just,
first thing that
if you
comes up
type
when
in, Headache on the Hill, or the website though is called Alliance for Headache Disorders Advocacy, and we call it AHDA for short. So if you're virtual with us right now, we're going to put you in breakout groups in just a few minutes. We're just going to wait until we're just going to let you watch us practice so you can get a flavor for what you need to do. And then we're going to ask you to go into groups of 3, hopefully, preferably with someone you didn't come with, but if that makes you feel more comfortable, that's okay, I understand. So, and then we're going to ask you all, we're going to ask you to come back, talk about your experience, and then hopefully somebody will come up and practice in front of the room. Okay, so now you really probably have to, the pressure's on, but don't let the pressure like trick your amygdala. So listen to what Dr. Thomolo told us earlier. So, okay, just tell, it's not scary. Okay.
Scary. It's safe practice,
Okay, so
safe
come
practice.
over here. And what would you like to ask? What would you like to say to me? So you're going to talk to me first.
I'm sharing my story.
Well, we should do a scenario. We didn't do this on our call, did we?
We didn't practice this, so.
Yeah. Okay. So I'll start first.
Okay, great.
Sarah, you've missed a lot of work lately, and I've heard from the HR department that you keep calling and saying that you've got headaches. And I just want to say, I don't understand why you would not be able to come to work if you have a headache. Like, I know when I get a headache, I can just take some Advil or Tylenol. Like, I work through it. Maybe I'll go put my head down on my desk for a few minutes, but what's going on? Like, you're such a great employee, and I really don't understand what's happening.
Thank you for that positive feedback. I appreciate it. I actually live with chronic migraine. So it's an invisible disease, a neurological disease. And it's complex in the sense that I experience not just headaches, but symptoms all over my body, including brain fog. I have dizziness on a regular basis, and it can be quite debilitating, actually. It's great that you're able to just take a Tylenol. Unfortunately, my condition is a bit more severe than that. In fact, I was born with this condition. It's genetic, and I've lived with it since infancy. I was a colic baby, and I believe I've had head pain since the day I was born, and it has chronified over my life. I experience symptoms almost every single day. I'm able to work through it sometimes, but there are many days where I am unable to. And I have to call into work or step away from my desk for a while to use the tools that support my body to be able to get back to work as soon as I'm able. But migraine is a severe disease, and I have some resources for you I can send you that would be really helpful for you to learn a little bit more about it. And we can maybe reconnect after I send those resources. Would that be okay?
Wow, absolutely. I had no idea that you were going through all of this. I'm so sorry. Is there anything that we could do here in the office that might help you?
Yes, there's a lot you could do, actually. I would love if you would implement a scent-free policy so that there would be no cologne or perfume allowed in your building, and also maybe allow me the opportunity to have an office without overhead lights and just lamp lighting, because lights can be really triggering for me.
Okay, I think we could do that.
Great.
Okay, thank you for sharing with me.
Thank
Okay,
you.
so. Okay, so let's go into breakout rooms. We're going to go in for
Sorry. Hi. My God. Oh.
7.
I don't understand, Patty, how you have how you have video.
I know, me too. I was just trying. I just double checked and I can't get my video on.
She didn't.
I just hit it. Yeah. I just tried and it wouldn't. It said no. Unable to start video. Because the host has stopped it.
Yeah, I just touched video and it went, it didn't go on for a while, but then it went on.
Oh, I've been touching it. I mean,
Yeah, so I didn't get it.
Ladies,
Yeah.
Helen, I've just reached out to Jason, who's on site. He looked, he doesn't see why you don't have video, but it sounds like, did you guys not get put in a breakout room?
oh,
We
we
did.
did. There were, but how many, Deb, did we start with?
We
Five?
started out with 3 people,
3 people.
and one of them was too sick to participate, and then the other one, her mic was broken, so we couldn't hear her.
Okay, so you stopped. Do you want to hop in another one of the rooms? I mean, I see that a number of the participants didn't go in a room. I don't know what that means, but
How much time do we have left?
let me see. Hang on.
Yeah, because if they're winding up, I don't want to jump in
Right.
if they've, kind of got their own groove going on.
No, they're in there till 1:20.
Oh, wow.
So if you want to hop in, and then in the meantime, I'll see if Jason can help. I don't know what's with the video. He checked it and he had no problem turning it on. So you're saying the button along the bottom, you can't get in?
Can't get in. It says, I just hit it, says unable to start video. You can't start the video because the host has stopped it.
Okay. All right.
Kelly,
Well, I'll see
saw
if they
you
can
for
get
a
that, but
minute.
maybe you guys can hop in for a second. And then
Okay.
hopefully it'll be better next time. Thanks.
Helen, can
Yes.
I get into, this is Patty, can I get, somehow I didn't get assigned, can I get into a room and help?
How are you signed up? What's showing when, does it say Patty Houghton?
It says Patty Houghton. Yeah, and I have video.
Ah, that's so.
Not like the rest
And
of us.
I saw Kelly's for a quick minute and then it disappeared.
That's what happened when I signed in. My face came up at first, and then it just was gone.
Yep.
But
Okay. Patty,
was
your name says Patty Houghton, right?
yes, and I was
You guys-
on my iPhone and I'm wondering, and I've just switched the computer because I didn't get anything. So I switched to
Okay.
this.
Okay, why don't you guys try and hop in a room and I'll see if Jason can do something for the next.
Okay.
Oh,
Great.
here it says I can join a breakout room now.
Perfect.
So I will just join one. Okay,
Okay.
let's see. Okay, now it doesn't give me a room to go to though.
Well, Because I see the
There you go.
room
What
now.
room? What room? Anything look?
Maybe the room, well, okay, 10, 9, 8, 11, and 9.
Okay, who wants to do? There's 10, 9. How about do the 10, 9, and oh, there's 11.
You want to join 11, Kelly?
I'll do 11.
All right, I can go to 1 since it's 10.
Okay. And if Jason can get me access, I can jump in. What room should I jump into? I can message Jason, I guess.
I don't
Anyone?
know why you're not able to get in, Patty. I don't know what
I
the
don't,
situation is.
yeah, he said he didn't, Tech did not, oh, you said C, and I think I wonder if it was because I was on my iPhone, but I see
I
Teresa's
see it
on.
now, so you should be fine. You should be fine for the next session, but you can't get into a breakout room?
No, it said breakout for about 1 second, and then the breakout disappeared. It said join a breakout room, so.
Okay.
But like, oh, here it is, breakout rooms. Let's see if I can get, oh, yes, which one should I join?
What did the other guys just say? I wasn't listening. Just pick anyone and hop in. And if there's too many moderators, go back out and pick another one. That's okay.
I will do that. Okay, bye.
All right, great.
You need to smell the cherry.
Okay, welcome back, everyone. Got some folks that are really communicating very well in this room here in Milwaukee. And I hope all of you at home have made some connections as well. So I was going to ask if you're interested in being called on from the Zoom platform, if you could raise your hand, and then we've got Dr. Collins in the background who can see all of you, who can choose someone that wants to share. Does anybody want to share a scenario or a story or or not a story, your elevator pitch? Anyone going to Headache on the Hill that wants to share? Okay, well, we're waiting for the folks on Zoom. I am going to bring our stellar volunteer, Jean, up to the podium. and it's going to go just fine. And it's okay to make blunders, and it's your first time. Like I said, the first time I ever had to do this at Headache on the Hill, I don't know what I did, but I got through it. So Jean, welcome. Come a little closer.
Come a little closer.
So I want you to know that Jean is wearing a shirt and it says, I'm fine, but actually the words fine have words in them: fighting, sleepy, in pain, not quitting, unable to work. And she's a hemiplegic warrior.
Oh, wow.
So that's pretty amazing, because if you don't know what hemiplegic migraine is, I'm going to share with you very quickly. It looks like you're having a stroke. And a lot of people with hemiplegic migraine don't get diagnosed because doctors don't understand what's happening. When we were at Retreat Migraine 2 years ago, there was a woman there having a hemiplegic migraine attack. And luckily there was a doctor right there. And I ended up taking her to the ER. And by the time we got there, she was okay. But it's very scary when it happens. So Jean and I are gonna, so Jean's a nurse and we're gonna set up the scene for you. So Jean, I'm actually Jean's friend and I'm a nurse also. And I'm gonna say to Jean, you know what? I'm so disappointed that you left working, because now our shifts are so complicated and, you know, we really needed you and you just kind of like left and we don't know what happened to you. You just deserted us and we really need you to come back. So what's happening with you?
Well, thank you so much for saying that. And I really miss everyone as well. I really wish that I could be there, but I am currently suffering from chronic migraine and hemiplegic migraines and vestibular migraines. And I'm not sure if you know anything about those,
No, I
but
never heard of that.
migraines are not just headaches. It actually affects my entire body, and especially when I'm having the hemiplegic migraine. So it mimics what looks like a stroke, but it all affects on just one side of my body. And there's pain and tingling sensations that happen. I have different muscle control. I lose some of that muscle control on that side of my body. Vestibular migraines, I really get kind of dizzy. And so it makes it very difficult for me to do my job. It makes it very difficult for me to fight through the pain that I'm also experiencing. So I would love to share some information with you about that so you can understand a little bit more. And I'm working really hard to get better, working with my physicians, my neurologists to try to get better to come back to work. But right now is just not a good time for me.
Excellent, right? Thank you, Jean. Yeah, that was amazing. I mean, you know, she said it very concisely and she explained what hemiplegic migraine is, because has anybody in this room ever not heard of hemiplegic migraine? Raise your hand. And now we all know what it is, right? And so we all actually learn, and it's good to learn about the different types of migraine. Do we have anybody on Zoom that wants to share their own scenario? Yes, we do. Who do we have? Dr. Collins, could you see anybody on Zoom that wants to share? If you want to share on Zoom, we just ask that you turn on your camera and raise your hand. And we're not getting anyone. Oh, come on. So the reason we do this, I can't stress this
Excuse
enough.
me. Shirley,
Yes.
this is Kelly. There are those of us who can't have our video on.
Oh, well, okay. So if you want to share without your video, just unmute yourself and say, I would like to share my elevator pitch. Now don't all jump at once. Okay, let me ask this question. Is anyone going to Headache on the Hill next week that wants to share what you're going to say in your meeting with one of your members of Congress? What are you going to say? Because you have 2 minutes to share your story. When we go to Headache on the Hill, we can't spend a lot of time talking, but we have to explain why it's important for Congress to pass certain bills that we're looking to get passed. And one of those is we want to stop, well, I actually can't say what they are because we have to wait till next week to announce them. Kelly, you want to share yours? Are you going to Headache on the Hill? You are, Kelly, right?
Yes, I am going to Headache on the Hill.
Okay, what are you going to say to your member of Congress when you share your story, Kelly?
Thank you, Senator Casey, for taking this meeting. My name is Kelly. I have migraine. I've had migraine since infancy. I had severe colic. I had significant motion sickness, and all the GI things are comorbidities of migraine. I started having migraine headache, the head pain, starting in grade school, which progressed through college. I was not diagnosed with migraine until my late 20s. By then, my neurologist transferred my care to a headache specialist because I had already begun to chronify. I was intractable chronic daily migraine by the time I was 40. And I developed vestibular migraine at the age of 58. I have one daughter who also has migraine.
Thank you, Kelly. So Kelly gave a lot of information in what she just shared, because like we talked about before, some people don't know what vestibular migraine is. And so it's important to explain to someone that, what is migraine, right? I mean, people think it's a headache, but because Kelly has vestibular migraine, she also has symptoms of dizziness, and that can land her in bed for days. I mean, imagine trying to function when you're dizzy, you can't. So anybody else on Zoom want to share their elevator pitch? There's Kelly. We see you now.
I don't know. All of a sudden, the screen said, "Start your video." Oh, and there's Deb.
Okay, and there's Deborah Turk. Deborah Turk, can you please share your elevator pitch? You're going to Headache on the Hill, and I just want to share that Miles for Migraine was fortunate enough to get a grant for bringing folks from the BIPOC community to Headache on the Hill because the BIPOC folks are very underrepresented in the headache community. And it's important that really everyone understand that there's different challenges that that other folks face. And so Deborah will be one of our ambassadors at HOH. So Deborah.
Hi, everybody. I want to preface this by saying that this is a rough draft that I prepared in anticipation of being able to be the person who fulfills the role of telling their story to the legislator. And the person that I'm preparing for is a congressman from my district, and we have a couple of connections because he is responsible for the founding of 2 of my children's school in my neighborhood. So that's why I'm prefacing this so that you can kind of understand that's where I'm coming from when I wrote this elevator pitch. Hi, and I don't have all the proper introductions and stuff yet. I'm sorry. Thank you for meeting with us today. My name is Deborah Turk. I'm from the Germantown section of Philadelphia. I've started to have episodic migraine attacks in college. Then as time progressed, they became chronic. Translation, they're difficult to treat, and there is no day that I don't experience pain. But migraine is a full spectrum disease with many symptoms. Sensitivity to certain types of light and chronic fatigue are 2 of mine. I was always a physically active person and parent. Now mopping the floor wipes me out. I came to look at myself as a bad parent because I spent so much time in bed. I was forced to leave behind my career in mental health, which I loved. I was devastated financially. I have tried almost everything treatment-wise. Currently, I'm fighting to get a medication reapproved that my insurance company approved for 12 months, last month, but now they say I have to do it all over again. This is an ongoing refrain for many people with headache disease, not just me. I truly believe if migraine and headache diseases were taken as seriously as the impact they have on people's lives, many of our issues would be resolved, or at least a lot less difficult. That's it.
Wow. We're getting a round of applause, Deborah. Deborah is an amazing speaker, and she has spoken for us on many occasions, and Deborah really knows how to speak to an audience as well. So did you notice that she said how it affected her life, that she's been devastated financially? You know, it's important to add that into your elevator pitch is, and actually Kelly was working on her PhD in nursing when she had to leave her career behind. And so those are some key words that you can, phrases that you can add in when you're talking to, you know, if you decide to go to Headache on the Hill, which I hope you all will, which will be virtual in the fall, it's good for you to think about this. You're going to have to be able to tell your pitch if you want to go. So thank you guys for being here. These two women are also virtual support group leaders, which we have virtual support groups. So they have been amazing, stellar volunteers at Miles for Migraine for many years, and I can't say enough good things about them. And I can see you too, Patty, also a very senior volunteer. We can see you on the screen as well. So thanks guys. So we're gonna actually take, we're gonna have lunch. We're gonna take a 10-minute break, let everyone go and get their lunch. We're gonna come back at 30 minutes past the hour. We're gonna do the Q&A session so we can let the morning speakers go home to their families. So please go and get your food and come back. We're gonna eat while we chat. And if you're in this room, so please go over and help yourself to food. And I know there's one person that still needs to check in with me. If you can come see me. While you're at it, write down your questions on a piece of paper over here. Just leave them there. And then also you can write your name down on a piece of paper for the 2 giveaway prizes we're gonna have at the end of the day. Okay, go and eat.
Wow, this is.
Recording in progress.
There we go.
Okay. All right. Good afternoon. Is everybody having a nice day with us? Thank you for hanging tough. All right. So while you guys are eating, we're going to cover some of the questions, and feel free to ask more if you are thinking of things while you're enjoying your lunch. So first one we'll address comes in from Robin. So side effects of living on Relpex. So about 12 pills a month or more. So I see some smiles. So here's where we kind of run into that medication adaptation headache, or that formerly medication overuse headache that Dr. Collins and I sort of touched on. So in general, you know, we like to try to limit, you know, on average treating headaches acutely no more than 2 to 3 10 days out of the month, because anything more than that might lead to this medication adaptation, medication overuse headache. So if you're at that point and you're not working on preventative means of treatment, that's when we'd have to start addressing that. So does that answer the question? Okay. All right. How is vestibular migraine diagnosed and different from vertigo? Okay. And what is an ocular migraine? Okay, so first question, vestibular migraine diagnosed and different from vertigo. So vestibular migraine is, so number one, you have to have diagnosis of migraine, and 50%, and at least 50% of attacks are associated with vestibular symptoms. So it doesn't have to be true vertigo. So vertigo is the sense of moving or the sense of like the room is moving around you. So it can, so with vestibular migraine, it can just be like dizziness, lightheadedness. So it's some sort of like vestibular symptom. And then you have migraine attacks as well. So, and 50% of those attacks are associated with these symptoms. So that's the definition that we use as headache specialists. Sometimes it's not aligned with our ENT colleagues, so we'll get some other dizziness referrals questioning vestibular migraine, and we're like, that's not quite vestibular migraine. Versus true just vertigo, which can be from a number of different things, inner ear issues, different causes of that, where it's that, like I mentioned, that sense of movement or that the room is moving around you. And an ocular migraine is essentially a migraine like visual aura. So that's, we don't really use ocular migraine terminology much anymore, right, Dr. Collins? Would you agree? So it's truly that visual aura that you're getting without the headache. All right. So this is kind of a pretty broad question, and I can help to narrow it down. And if the person putting in the question wants to clarify, but side effects of medications. So do you have any specific ones you want to ask about? Because I can definitely go through as many as you want and potential side effects of medications. Okay.
I try to start with I'm a child life specialist by background and training, and I try the non-pharmacological first, and then go to like Advil, Tylenol, and then the next step. And I think at our table, a few people have shared just the impact of the side effects were worse than the headache.
Mm-hmm.
If you can address a little bit of that.
Yeah. So, like, are you talking about like the rescue medications in general and things like that? Yeah, so I mean, it really is trial and, oh, sure. So the woman who put in the question was just saying she, with her background and everything, she prefers a more, natural approach to treating her headaches. And so she usually treats her migraines with Tylenol, ibuprofen, and then even with talking with individuals at her table who have tried more migraine specific things, sometimes the side effects of those agents are maybe even worse than the headache. So is it really worth it to use those medications? And yeah, I mean, sometimes that is the case. But there is a lot of options out there, especially too with these newer options as well. And it, I hate to say it because when it comes to, how you're feeling and, what you're experiencing, that, oops, I don't know if we really need that up there, but it is, it is trial and error before we kind of find, what is gonna abort the attack and what is going to, not cause side effects. There's no way of predicting that necessarily. I mean, we do know, in general, from, using the medications and through the studies, what typically, has less side effects versus others. So, we do know that, and we can make those recommendations, like if we look at the triptan class of medications, for example. So the longer acting ones, such as niratriptan and frovatriptan, tend to have less side effects than your sumatriptan. I mean, we do know that in general. And like the newer G-PANs, like rimegepant and ubrogepant, those definitely tend to have less side effects that we're seeing than the triptan. So, so we do know that from like the studies from using them, but again, everyone's different too in terms of how they'll respond. And again, we won't know that until we see how you respond as an individual. Does that help answer?
It does. I just, working in healthcare for as long as I have, I've seen a lot more side effects with a lot of medications.
Yeah. Yeah.
Some work really well and some.
Yeah. Alrighty. Oh, yeah, there's an online question about, yeah, treating teens with migraine, and I think it said something about them missing extended amounts of school. So in our practice in adult neurology, we don't treat a lot of teens, but I do have a handful of teens that I do treat. But like, Sarah brought up and other folks have mentioned in their, elevator pitches, my son who's 8 has migraine. I mean, migraine can affect people at any age, and it can start at any point in time, and, kids as well. And so I would advise the individual on the Zoom who put in that question that if the teen is not already established with the neurologist that is managing their headaches, it's important to get on this sooner rather than later, to prevent progression of disease that we talked about, so that they, aren't missing school, that they aren't missing out on life, and they're not suffering from this disabling condition, because that can get pretty tricky. There's a lot of evidence for preventatives, rescue medications. I mean, less so than in the adult world, but still there are a lot of treatment options for children and adolescents. So. Sarah said there's a resource called Migraine at School. Okay, Shirley will put it in the chat. And let's see. Oh, that's a new one. I didn't see that one. Okay. Okay. Okay, someone asked where Emgality falls with side effects. So Emgality is one of the monoclonal antibodies, CGRP monoclonal antibodies. So similar to the other monoclonal antibodies, again, minimal side effects, which is why these are great options for our patients. Common side effects in general with the monoclonal antibodies, including Emgality, injection site soreness and reaction. I mean, they can be painful for the patients. I will have a say that patients say, oh, that kind of hurt when I injected. And some patients do get a pretty good welt, a little, reaction site reaction, that we can pre-treat with some Benadryl, some Zyrtec. But in terms of other side effects, that is mainly the ones that we see. I've had a handful of patients have some hair loss to these newer class of medications. But again, it's a small number, but for the most part, these are very well tolerated. What's nice about them too is that they, the monoclonal antibodies are big molecules, so they're quite big that they don't cross the blood-brain barrier, so you're not having the cognitive side effects. So they're acting peripherally on that system at play in migraine without getting too technical into the pathophysiology, but so they're not going to cause sedation, cognitive clouding, that stuff that we see with the other oral agents. So how do I envision expanding migraine awareness throughout the headache or healthcare community? And healthcare providers need to be aware of resources available to their patients. So this is a big passion of ours, patient advocacy, community awareness. We have the wonderful help of Miles for Migraine. So 3 years ago now, Miles for Migraine wasn't a part of Milwaukee. They've been around. So when did Miles for Migraine start? 2008. 2008, yeah. So they have many sites nationwide that they help to support fellowship programs so that we can train more docs to become headache docs, because there's such a shortage of our specialty to help the millions of Americans who suffer from migraine, let alone all the other headache disorders. And so 3 years ago, I was like, I want Miles for Migraine to come to Milwaukee and help bring awareness to our community that this is prevalent in our community, so that we can, help support our patients here in Milwaukee and Wisconsin. And so a group of us just went to the park and made signs, Miles for Migraine, and we're like, we're going to show that, we support migraine. And then lo and behold, we got their attention, and we now have the race come to us every year. So we're long story short, we're trying to create these sorts of events to help raise community awareness and support our community, and through these, community education events. Does that help answer the question? Jen, do you have anything to add? Dr. Thumala? Any other questions from the audience? Yes. Mm-hmm. Mm-hmm. Yeah. 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 So we commonly see that. We like to refer to that as like the letdown migraine. So it's like you're going, and then finally you have that like opportunity to relax, and that's when it just decides to hit you. Yeah. And I'm not sure if there's like a real like pathophysiological basis for it, but that's what we refer to it as, is that kind of like migraine letdown. Yeah. Yeah. Right. Right. I mean, yeah, it's tricky. I mean, if there is a pattern to it, like if there's a pattern, or if you have like any of like warning signs, like later in the week leading up to that letdown, if there's a way to maybe pre-treat or provide like maybe a mini prophylaxis leading into that, kind of like what we do with like menstrual migraine and things like that, so again, getting back to keeping a diary to maybe identify more patterns and specific trends to that, to maybe even ward off that, like if you notice it's always specifically on these types of work weeks, that's when it falls. Like, could you ward it off by maybe scheduling one of your rescues like the day before that were to hit, to see if it would prevent it from hitting, so we try to get creative like that. So maybe keeping a good, journal just to see if you can identify that. I don't know. Right. Right. Yeah, because I've had patients even see it like, well, why am I having more headache on the weekend? Because I'm getting even more sleep. That doesn't make sense, because then sometimes, well, maybe now they're sleeping so much more soundly and now they're sleeping funny on their neck. You know what I mean? Like, who knows? But it's like a change in their pattern. So, yeah. Good point, Sarah. Yeah. All right. Any other questions? Anything for Dr. Thumal? Are you done eating?
Yeah, so I think that I've heard something similar about often patients will tell me that they're just go. One day relax, that headache. Part of what we do is the care says sometimes
Yeah, so, when people are kind of in that go mode, there is a certain amount of stress that you're just kind of pushing through. And when there's that sudden change in stress level, it's that change that your brain is reacting to, that it can feel like there's something different and now I'm going to trigger a migraine. So from the psychological perspective, what I would recommend is managing stress throughout the week as best as you can. So not kind of being in that, I got to push through, yeah, all week. And so there isn't this abrupt change.
That makes sense. Before I let Dr. Thumala take over for her Q&A, yeah, or from me, I don't know if there's any from the audience, but
There was one that just was posted. I've noticed a major decrease in my headaches with using ultrasound on my neck and back muscles to kind of work out the knots. There was a question about time limit recommending to spend on each.
Time limit?
How much time to kind of spend doing that. And I don't know, that's not really our area of expertise in terms of, how much time to spend, with massaging the neck or with ultrasound. However, we do refer people all the time to physical therapy to kind of work on the neck. They're very knowledgeable about that. So I'm really sorry, I don't think we can answer the question about, how much time to spend, but that brings up another good point about physical therapy. Maybe it won't help, but a lot of cases it does, especially if you feel a lot of neck and back tightness and you feel like that could be a trigger. Going to a therapist that can work on that, can kind of work on exercises and work on kind of strengthening and range of motion and things like that can be another tool in the toolbox.
Do you
Yeah.
refer people for dry needling?
Mhm. Yes, we do. Physical therapy does that, and a lot of people say that it helps. Absolutely.
My husband had it for his shoulder and he's listening and finding out, and he's like, oh my God, this could help my wife.
Yep.
But I
Yeah,
haven't
yeah.
ventured that far yet.
Yep.
And I think at
One
Freight,
thing at a time.
at least at Freighter, we do have physical therapists that do dry needling specifically for migraine and for like the cervicogenic, we call it, where it kind of is coming from your neck, with the tightness.
Evaluated
Mhm.
and, you know,
Exactly, yeah.
Mm-hmm.
I'm doing the shots, so I've just done 3 of the hemo week.
Oh, great.
Nice.
So my 4th should be soon, but
Nice.
Mhm.
Nice.
they got breached last week.
Oh, yes. Yes, that's been an
So,
issue.
I'm not guaranteed $5, so that right now it's $252
I know.
is my copay.
I know.
Ouch.
I know.
Yeah.
I got
I
hacked.
mean, it's financial decisions.
Right. Right.
Yeah, so just repeat that, the copay, do you know about the copay assistance plan? Or
Uh,
program?
hmm?
Copay assistance program, do you know about that?
Yeah, the $5.
Okay. Oh,
I've
yeah.
been using
Okay.
specialty pharmacy in Shorewood.
Okay.
So instead of Quad Med Pharmacy, so yes, my
Okay.
husband works at Quad, so we do have good insurance, but that's what they came back to me yesterday. So I said I'd wait to see.
Because the company
Monday
got
if
breached.
The breach is
Yeah.
better.
Yeah.
But yeah, that was their answer on Friday afternoon.
Oh. Yeah, I had a couple of patients affected by that
Yeah.
as well.
I think those were the outliers.
Yeah. Okay. Okay.
Yeah, perfect. Thank
right.
you. That
Yeah.
was great. Thank you. Okay, we're gonna transition now to our final presentation, and I just want to say we will be doing a drawing at the end of the program. I'm going to do a short presentation about how to talk to your doctor HCP about migraine, and then we'll do another breakout session, and hopefully we'll get a volunteer. And after that, then we'll do the drawing. And if you're online, if you want to be included in the drawing, you need to just have your first name. You still have to be present to win. If we call you, if we end up choosing you and you're not there, then we're just going to pick another name from the hat, because we know sometimes people leave their Zoom on and walk away. So we also, if you haven't if you're in the room here with us right now, please come up and write your name on a piece of paper and put it in a little box, or just write it on any piece of paper you have at your desk. And we want everybody to be here for that. So we'll be sharing with you what will be, one of the products we're giving away is the Ally lamp, which is a green light. It's valued at $300. And the other prize is a pair of TheraSpecs glasses, which are valued at over $100. And so stick around for that. Okay, thank you. So let's talk about communicating with your doctor or healthcare provider. And just a little bit about me. I am someone that lives with chronic migraine. Migraines affected me, I say, since the day I was born, also because I had a mother who was debilitated by migraine and spent a lot of my childhood in bed. And I was the oldest of 3 children, and I was left to care for my siblings and my father, who didn't understand. So when you talk about family members not understanding, I love my father very much. Don't get me wrong. He was great, but he truly just did not understand why my mother was as sick as she was. And it really affected our entire household. So again, you know, this is just an introduction about migraine being a complex neurologic condition. And I'm really now speaking to everyone, you know, people on Zoom too, if there might be people joining us today who really haven't talked to their healthcare provider about their headaches and other symptoms. And sometimes, you know, is there anyone here that goes to a primary doctor that treats them for migraine? Okay, and was it hard for you to get your doctor to understand at first what you were going through? Or she has a migraine as well? Okay. How about you? Was your doctor understanding?
I think to some extent, but it's
To some
kind of
extent.
like, I mean, I think right now I think I need
Oh.
probably need prevention versus just, oh, here's some
Oh,
sumatriptan and,
okay. So, yeah, so what the person here is saying is that she thinks she needs preventive therapy now. And thank you. And that just taking rescue acute treatment is not working for her anymore. So it's important to take information to your doctor so that way you don't waste a lot of your time. So one of the reasons that your physician may not be prescribing preventive therapy is because doctors don't get a lot of training in headache medicine. And so they don't really know how to treat it. And they don't want to treat us because some doctors don't want to treat us. And here's why, because lack of training, sometimes we don't get better. It takes a really specialized doctor. That's why headache specialists are so crucial to us getting better. We're hard to treat, and sometimes they think that we're seeking opioids. We're seen as drug seekers. So you should have a handout. Key point number one, obviously prepare in advance. So you want to write down as much as you can about your migraine history. Like for me, for example, it was important for me to tell my doctor that my mother had migraine because migraine is also hereditary. It's important to talk about trauma. We know now that trauma in childhood especially, can actually cause migraine later in life. And so write down your symptoms, because who here just has a headache and no other symptoms? No, we have a lot of other symptoms that we're dealing with. Again, be clear about, your symptoms. You want to describe the nature of your migraine attacks. And by the way, just as an aside, when you start learning about patient advocacy, we don't say the word migraines anymore. We say migraine attacks, because migraine is actually an attack. Migraine is something that we have all the time. Once you're diagnosed, you have it, just like you have asthma. And we don't say I am having asthma. We say I'm having asthma attacks. It's the same with migraine. So just a little thing you can take home with you today. You want to talk about the frequency, duration, and the pain intensity. You want to talk about your other symptoms. It's important to talk about aura, sensitivity to light and sound, dizziness. And this is probably something that is really important, is to explain how your symptoms affect your life. I've had headache doctors say to me, I wish more of my patients would not just come in and say, well, I'm getting 15 headache days a month. Because if you go to a really good headache specialist, they're going to want to set up goals with you. Like, is one of your goals to be able to go to a concert or a live performance? Maybe your goal is to go to the gym more. Maybe your goal is just to get through the work week. And so it's important to share that information as well. You want to talk about triggers. We know stress is a trigger. Food triggers, something I know that was actually a question that was in the chat. I think I forgot to mention it, but something that we still don't know enough about are food triggers, because there's not enough research. So it's not all evidence-based. We know hormonal changes are important. So maybe if you're someone that just has menstrual migraine, it's important to talk about that. It's really important to talk about your medication history because there's something that insurance companies use called step therapy. Does anyone not know what that is? Does we all know what step therapy is? We all know. No, we don't know. Okay. So yeah, step therapy is when a doctor will say, okay, if you want to get one of these new CGRP blockers, which are the new therapies on the market, which have the least amount of side effects, by the way, then you have to try these other 2 or 3 medications first before I'm allowed to prescribe those medicines for you. If you've already had those medications in the past, then you need to tell your doctor, I've already been on Topamax, I've been on, you know, like Dr. Schlomer was showing us early, I've been on an antihypertensive, because we already know then these drugs either had too many side effects for you or they were not working. Again, goals, like I talked about before, what is it that, you know, because everybody, if you go into your doctor and say, well, I just want to be headache free. Okay, well, we all want to be headache free. So do I. Unfortunately, you know, unfortunately that can happen for some people, right? But it doesn't happen for everyone. And so maybe, you know, again, your goal might be, you know, I've talked to a headache doctor who said to me, well, if my patients want to go to the gym, then I have a different protocol for them to use than if they say to me, I want to go to a concert or a live performance. So just something to think about when you're talking with your doctor. You always want to ask questions. You know, ask about the newest treatments if you're not already on them. And also, you know, obviously you want to ask your doctor if you walk out with questions and you didn't get them answered, you want to try to get them answered there. And the thing about migraine is that it is complicated. You're not going to get all of your answers in the visit because doctors have limited time. And that's why being here today is really important for you because I'm hopefully you're learning something today that you didn't know before you came here. And check out, there's a really good community of a lot of nonprofits online. We all do different things. But Miles for Migraine, all of our programs and services are always free. So check out our YouTube channel. Ask for a referral. So if you are someone that's if you're seeing a neurologist or you're seeing a primary doctor and you feel like you need to go a step further, ask to be referred to a headache specialist. And you can explain that, you know, you feel like you could hopefully you would ask that because you want to be doing better or treatment's not working for you or having side effects. And again, collaborate on your treatment plan. It's important to, when you walk out of there, to feel like you've done this together, right? Because you have to be part of the process when you talked with your healthcare provider. And again, you learned a lot about non-pharmacological therapies today. This is something that a lot of doctors don't have time to talk about because they're busy and you have limited time. And so it's important for you, though, to share that information if you are seeing a provider, to let them know that, you know, I've heard about this medical device and I went to an education event and I want to try this. And by the way, it's exciting news is that the Nerivio, which is the armband, I don't even know if you guys knew this, just got approval from Highmark to be reimbursed. So that is the first time a medical device is being approved by an insurance company. This is the first time ever in the history of migraine. And a lot of this has to do with the migraine community, and they did a lot of work to do it too, but the migraine community is really making a lot of noise. Patience and, of course, persistence and knowing how to tell your elevator pitch. So, you know, again, if you have to advocate for yourself, if you feel like you want to have, you know, there's something you're not getting, then you obviously want to be assertive and respectful. If your doctor just seems like they're uninformed or unresponsive, then go get another opinion. So in conclusion, effective communication is always the key, no matter what you're doing. And being prepared, being clear, advocating for what you really want. You can work collaboratively with your healthcare provider to find the best solutions and manage your treatment. So what we're going to do now is we are going to break up into groups again. If you can try to find a different group, that would be great, but I know we all like to feel comfortable. So if you want to go back to your first group, that's okay. I think it's really good though for you all to sort of meet other people here today anyway. Part of Miles for Migraine, our mission is to create community, and we want you to meet other people who are on the same journey as you. And then, you know, you guys can meet up again. You can meet up in August again when we have our walk run. You can say, I'm going to go to this social event. I mean, this is your people. So anyway, so I would say, you know, use your tips and tools worksheet to craft your story. If there's something that came up for you and said, you know what, I haven't asked my doctor about this, and this is what I want to ask next time I see them, maybe that's something that you want to practice saying. And you can or go through the worksheet and write down, jot notes to yourself right now, and just work with each other. So we're going to do this until it's 5 after the hour. We're going to do the breakout rooms again. Is that okay, my people in the back? Okay, they're getting there. You're going to be broken out in Zoom, and we're going to come back at 20 minutes past the hour. And if there's anyone that wants to share, if you had any aha moments, we'd love to hear them. So let's break out right now.
Are you seeing how to get in? No.
Not yet.
No.
No.
Maybe they forgot about us.
Yeah.
I think they might put you moderator.
Okay, welcome back. Our in-person room is still chattering. A lot of new friendships are being forged. A lot of new headache and migraine friendships, which we all need someone in our, we need someone in our corner. So get each other's phone numbers and emails and try to stay in touch. Join a support group together. Okay.
Tribe bigger.
What?
Your
Kelly?
tribe grows, right? Your support tribe grows.
That is, it's a support tribe. That's exactly what it is. So, okay, so welcome back. So I'll start with our in-person room, and you guys online, think about if you want to share anything that happened in your breakout room. You don't have to tell your elevator pitch if you don't want to, but you can just share anything, any aha moments you had while you were chatting. Could be even about something else. So I'm going to just ask for a show of hands here. Anybody in the room want to share anything? Yes, can you come up here and so everybody can hear you online? Thank you. And tell us your first name.
Hello, I'm Chris. We kind of had an aha moment right at the end. We didn't really get into it, but that we haven't really talked about the whole menopause, perimenopause, postmenopause, all that stuff and the effect that that potentially has. Because then that's kind of also where you start hearing, oh, it's just that, you know, before it was just your period. Now it's that. So just haven't, I'm surprised we didn't, and I forgot that wasn't, I forgot to ask that question when we had our Q&A, but
okay,
that was kind of the
well,
other
I
one.
say something about that. And yeah, I want to just chime in about that a little bit. First of all, menopause is something that most women don't talk about no matter what, whether you have migraine or not. A lot of, you know, now that I'm in the headache field, I see that I hear all the time from patients that even their gynecologists aren't really talking about menopause either. There is a movement that's starting to get menopause more into the mainstream. And I will also say that if you go to our YouTube channel, we do have a talk by Susan Hutchinson, who's a fabulous doctor, and she does a talk on hormones and headache. I don't remember if she talks about menopause in there, but I think she might. So maybe check that out. But we also just want to let you know that in the migraine community, we are working on getting ACOG, which is the the Academy of Gynecology and Obstetrics, trying to get them to diagnose migraine in a visit, you know, in the intake with patients. It's something that's not being done because a lot of women are going to their OBGYN and not talking about their headaches, and it's not getting diagnosed. So it's something we're trying to do in the advocacy community. Okay, thank you for sharing that. So if you go into your OBGYN, you know, these are some important things that if you know someone that's not diagnosed, you could maybe even give it to them and help them to go in and talk to their gynecologist. Okay, anybody else have anything in here? Yes, come up. And then we'll see if anybody online wants to share. So think about anybody online if you want to share with us any takeaway. Yeah, watch your stuff there.
Hi, I'm Leanne. We were talking about different scenarios with our doctors and stuff, and I had forgotten that I saw my neurologist and we had gotten all the drugs I could take, all the preventatives, all the things like, and he finally sat me down at one visit and said, I can't help you anymore. You are so complex with your migraines because I have hemiplegic cervigenic and vestibular migraine, that I need to send you to someone who's more advanced in taking care of you. What I appreciated was that he heard me and that we had talked about it at each visit. And when he realized he didn't have the necessary tools, he was willing to seek out someone else to find out. And he had literally given me 2 names so I could find that doctor if they fit in my insurance. And when it didn't, he fought for me to make sure it got covered by my insurance so I could get the help that I needed. So sometimes even, doctor, if they're willing to work with you, will fight for you. But it's being open and honest about what's going on and letting them take care of it with you. That helps a lot. That and the nurse in the office, let me tell you, she's got insight. Sometimes they know the ins and outs that the doctor doesn't always know. So always rely on them nurses too.
Yeah, absolutely.
Thank you, Leanne. That's so true. And at our last education event, which we just had in Phoenix, Dr. Amal Starling spoke for us. And it's a really good lecture, by the way, if you want to go back and listen to it. I think it's on our YouTube channel. It'll be going up soon. She says to her patients, I will never give up on you. I mean, wow, that's amazing, because migraine is so complex, and it takes someone who's really in the trenches with you. So anyone else in here want to share any aha moments, any takeaways? We can go to our online community if there's anyone. Can we see anyone online? Can you see everyone? Does anybody have their hand raised? Or you can just unmute yourself and just start talking. We're very informal at Miles for Migraine. We don't.
My name is Dina Wallace, and I just wanted to mention how I've tried, migraine glasses, physical therapy, vitamins, injections, pills, abortives, preventatives, physical therapy for 3 months, and Botox injections, and I haven't had relief. Oh, and elimination diets too. And I haven't had relief. There are some days that I feel better than others. And I think overall with, the current treatments that I have, and I tried Cephalid device on my head. But what I found is that like small incremental improvements are still good.
Well, I'm glad to hear that you're having some success. And I would say I can definitely join with you in what you've gone through. I've been on this journey since I was 23, and I'm 62. So, and I still have chronic migraine, but I can just say from my own experience that pain reprocessing therapy is helpful, and mindfulness interventions were helpful for me. And so while for me, I still have headaches and other symptoms, I've really just learned how to be accepting of it. But having good days and bad days, but thank you for sharing that. So anyone else online want to share anything? Just unmute yourself. And anybody in this room? Somebody here wants to share something. We're all shy. It's the end of the day. I get it. Well, we're actually probably going to finish early because we got a lot done. I'll give the online folks another minute if you want to share anything, any takeaway moments, any aha moments. If there's anything that you want to share about today that does anybody feel like you have any lifestyle changes that you're going to make when you leave here? Anything at all? Like, do you feel like something here was life-changing for you, or perhaps helpful in some way, even if it was just meeting other folks and knowing you're not alone. I hope that was of some
Hi.
use. Oh, hi.
My name is Leslie. I'm calling, or not calling, I'm here from Philadelphia. And this is my first event, education event, but I've been a part of different other events, social events through Miles for Migraine over the past, I would say 2 years. I love the feeling of the camaraderie. I wish it was for other reasons, but I really appreciate the fact that because of the health issue that I am not in it by myself. I appreciate the people who I was able to be in the breakout rooms with, because I heard things that were similar, but also new things that I can take and move forward. I heard wonderful things in the presentations. Some were things that I forgot to mention about myself, is and not feel that it is something that I should minimize or not speak about at all, that I deal with every day, because it is a part of who I am, but it doesn't define who I am. And I'm working intentionally to remember that, to always move with that. And also appreciate the fact that I have been fortunate to have good conversations with my care team. And I'm also glad that I spoke to my physical therapist about wanting to be able to have a space that I can just pour out all of the everything that becomes so overwhelmed about living with chronic migraine. And because I said that to her, she then directed me to a person, a pain management psychologist, who another patient of hers had a really good outcome with. So to all of us, I just want to say, keep going, keep your head up, connect with support groups, because that is a space that is so valuable. Even if you just allow yourself to be in it, you don't have to say or share. Thank you to everyone who presented today. I've been in the cycle for 3 days, and I appreciate listening and educating myself as much as I can. Have a great rest of the weekend, and everybody keep your head up.
Thank you, Leslie. That was very, very nice. Thank you. I think everybody in this room here appreciate what you just said. So I'm going to let you say something, Dr. Collins.
There was an online question about continuing education opportunities and credits for physicians. And I wanted to kind of comment on that. We've got a lot. We first of all, in order to maintain our medical license, we do need to do continuing medical education every year, certain number of credits every year. And there are a lot of different opportunities, things that we can do both, in your institution and nationwide and worldwide. And yes, I have seen opportunities regarding headache, but probably not as many as there should be. And probably some that could be directed towards certain groups of healthcare providers. So I was a high school biology teacher for about 8 or 9 years before I decided to go to medical school. So I was a little bit later. I had kids, had a family, and I loved teaching. I loved high school biology. I loved teaching. And for lots of different reasons, including a move with kind of jobs not available at the time, I thought, hey, I've always wanted to go to medical school. I'd love to do this. And I found headache. I found it was a great opportunity for really working with patients, helping patients, kind of a joint education. Patients educate me all the time on what they're dealing with and what their symptoms are and everything like that. So it's kind of working together. But one of the things that I would love to do is see more opportunities for primary care providers, because wouldn't it be great if primary care providers had tools that they felt comfortable with starting certain medications. So by the time you see a headache neurologist, you've already been through a couple of oral medications, you've already been through a couple of triptans and everything else, so that you can kind of keep working towards maybe some of the medications that primary doctors don't necessarily feel comfortable with. So that's actually something that I would like to work on in my future career. And then the last thing I want to say is just on Miles for Migraine. As a headache fellow, I was kind of told about this, advocacy training program for fellows and patients, and it's, Act Now and Miles for Migraine. I know it's something that you should do. And from the very first meeting, I was just floored by how upbeat and positive and helpful that this organization was for migraine sufferers. And, everyone was so upbeat and sharing stories, and not all of the stories were happy stories. A lot of them are not, but people were really able to share what they learned. And these are my experiences, and here are some thoughts for things that you can do. So I would encourage everybody, if this is your kind of first foray into Miles for Migraine, or maybe you did the walk, but this is your first educational event, email about that advocacy training program. It's one meeting a month, and I think December there isn't a meeting, and I think we end in April, and it's online, and it's an hour and a half, and it's just wonderful because it's that community of people who are going through what you're going through. And it's just really, I always leave the Miles for Migraine and I'm just like, wow, this is great. I'm going to go change the world. This is amazing. And so it's just a really uplifting experience. So reach out, email, one meeting a month, and I guarantee it will be a great, 2 hours spent.
Good. Thanks, Dr. Collins. Thank you for sharing that. And you'll get a newsletter about it very soon. So we start again in August, and if you're interested, it goes out in our newsletter. And now you will all be on our newsletter because you came to this event. So, okay. So I think we're going to pause here. And
excuse me?
Yes.
My name's Stephanie, and I'm actually online. What I meant by the continuing education is I'm a nurse. And for this event, are you offering continuing education hours?
Unfortunately, we're not. We do not offer CME at Miles for Migraine.
Okay,
but,
thank you.
There are a lot of online CME things too for nurses.
Yeah.
Through AMD, Association of Migraine Disorders, just letting you know. But okay, sorry about that.
Thank you.
So we have a few things left to do. We are going to do the drawing. We are going to also do the post survey, and I want to talk with you a little bit about the additional research project that Miles for Migraine is taking part in, which we are offering. Oh my gosh, I don't know if it's $250 or $300 now, I forget. But if you're interested in the post survey, you'll have the option to, I guess, put your information there. If you're interested, let me just share with you a little bit about what that is. So we are working with a sociologist who we are looking into the behavioral interventions for people living with migraine disease. And it's a real world study in the sense that if you are chosen to be in this study, you will be asked you have to visit your healthcare provider before May 31st. You need to have an appointment, and you will be, you'll download an app, and you will be asked, you'll get some questions asked, here are some of the things that you need to talk to your provider about. What are you going to talk about? That's why another reason why we did this presentation today on how to talk to your provider. What is it you want to say? Why are you saying it? And then you're going to record yourself with your phone, but you will have the researcher there along with you to help you, prompt you, ask you the questions. You can ask her any questions you want. And then it'll be like a pre and post visit. It doesn't necessarily have to be a healthcare provider. It could be your employer. It could be friends or family. But we want to know how effective this program was for you. and what the takeaways were and how can we improve it. And so the only way we're going to know that is by you participating in this research project to see whether or not it was effective for you. Because if you just came here today and sat in a dark room and went away with nothing, then we really haven't done a good job. And so, so anyway, we're gonna, you're gonna be asked to join that if you want in the post survey, which we are going to do now. And then we are going to, actually, we're gonna do the mindfulness exercise first, and then we're gonna do the post survey. And then we're gonna do the drawing. So is anybody here? I guess you might want to, I'm going to just lead you in a brief meditation. Actually, I was going to do some movement, but I don't think we have enough room for that. So let me get my chair and I'm going to come and chat with you all. Sorry for that noise. Okay. Okay, since we did some education today in mindfulness, I just want to lead you in a short mindfulness meditation. And I just want to start by saying that it's not for everyone. You know, some people don't really like meditation, and that's okay. And meditation's not about trying to clear your mind. So that's not what we're going to do today. So hopefully that makes it a little more inviting. So let's start by finding a comfortable position. And if it feels right to you, you can put your hands, the palms of your hands onto your thighs and sitting up, but feeling comfortable. And then if it feels okay to you, closing your eyes. And if that's not okay with you, then pick a gazing point someplace in front of you on the table or on the floor. If you're at home, someplace that you can just lightly rest your eyes, looking downward. And just start now by noticing how you're feeling. Noticing what's happening in the mind. Is the mind calm? Is it racing? Are you noticing a lot of thoughts? And you don't have to change anything. This is just right now, we're just noticing as if you were looking down from the forest into the trees, and you're looking down at the ground and you're just observing yourself. You're not trying to change anything. And once you've noticed what's happening in the mind, notice what's happening in the body. And without focusing on your head, because that's not what we're going to do today. We're not going to focus on our headache. We're going to focus on some place in the body that feels neutral. So perhaps it's your hands or your feet. It could be just your pinky. But see if you can just rest your attention there just for a moment where you don't feel any pain or discomfort, but just noticing a neutral part of your body right now. And if nothing comes to mind for you, you can just go right to focusing on your breath. And now we are going to turn our attention to just breathing. There's no need to change your breath in any way. So simply noticing right now as you inhale through the nose and allow your breath to travel into your lungs and into your rib cage and belly. And on the exhale, the breath can come out through the nose or through the mouth. Just noticing how your body is breathing right now. You may notice that the air is cool as you inhale through the nose. And on the exhale, the air may feel warm. Perhaps you can notice where you feel the breath most strongly in the body right now. And rest your attention there just for a moment. Perhaps you can notice sensations of the breath. One thing you will notice is that the mind has probably wandered away from the breath, and that's completely natural. And every time the mind wanders away, you can notice, oh, is the mind wandering into the past or in the future? Or is the mind thinking about planning or worrying? And just notice what the mind does, and then come back to the sense of breath. And just focusing again where you feel the sensations of breathing as you just sit here with nothing else to do right now, but just sit and notice. And what's happening now in the mind? Sometimes it's helpful to give thoughts a label, such as thinking, planning, worrying, questioning. And you can just repeat it to yourself if you find that helpful. Thinking, thinking, planning, planning, worrying, worrying. Because it's completely natural for the mind to wander away as we are sitting here and wanting to just focus on the sense of breathing. Noticing what happens in the mind now when everything is quiet. Perhaps you're noticing sounds in the background, and allow your mind to just notice sounds and then come back to the sensation of breathing. And where has the mind gone now? Gently yet firmly returning your attention to where you feel the sensation of breath in your body right now. Perhaps you notice it in the nose. Perhaps you are noticing the sensation of breathing in your throat or your mouth or your chest or your belly. See if you can rest your attention there just for a moment. And as this practice comes to an end, now take a moment and notice how you're feeling. Has anything shifted? It could be positive, it could be negative, it could be neutral. There is no right or wrong way to feel. But just see if you can come up with one word right now. Notice how you're feeling. And then when you're ready, you can gently open your eyes and come back into our space. Okay, does anyone want to share one word that came up for you at the end of the practice? Just call it out. Peace. Okay. Calm, hopeful, tranquility. Anyone online, you can unmute yourself and call out a word that you're feeling right now. Could be negative, positive, neutral. There's no right answer or wrong answer.
Calm.
Quiet.
Lighter.
Okay, thank you, everyone. Thanks for participating. Okay, so we're going to shift now. Hopefully that got you settled enough to do the post survey. But before we do that, I'll share, do we have the post survey link back there that we're going to put in the chat for, it's already in the chat. And then after that, we're going to give it until about 3 minutes past the hour. I don't think it'll take longer than that. For the people in the room, I'm going to give you a QR code unless anybody needs paper. I have some paper copies. Do I have a volunteer that wants to help me? You need paper? I do. Okay. If you're still doing the survey, don't worry about it. Just keep working on it. Thank you for taking the survey. And since those of you stuck around, you're all now part of the giveaway prize. The first one we're giving away are a pair of these TheraSpec glasses. Can they see these online if I hold them up? They can see me still, right? I don't even know. It doesn't matter. Okay. What do I have to do to go back to the Zoom? Can we go, how do we go back to Zoom? Do I click on a tab? Oh, they can still, so they can see me. Oh, okay, fine. Okay. These are the glasses. And they will get mailed to you. So I need my volunteer up here. Sarah, who's chatting over there. What? She's like talking in school in the classroom. Okay, this, yeah. There's a lot of people in here, so I'm mixing these up. So I wish I had a real hat, but I don't. So close your eyes and choose one name. That's my handwriting.
That is your handwriting.
My
Someone
terrible
online.
handwriting. This is someone online. Lisa, are you still here? If you are, you need to unmute yourself, because if you don't, that means you left and we're going to keep going.
Yes, I'm here.
Lisa. Hey, Lisa, where are you from?
Des Moines, Iowa.
All right. Well, Lisa, here's what I need you to do, because I don't have a very good memory. So write this down. Shirley, SHIRLEY, at milesformigraine.org. That is my email address. I need you to email me your address so I can mail you these. Okay?
Okay, thank you very much.
This is how we roll. Very easy breezy. Okay, thank you, Lisa. Congratulations. All right, now we have another one. Now this is for the, I gotta switch the tab. Okay, so listen, I put the TheraSpecs on here. If anybody's interested in learning more, they are really great glasses. They're just one of many companies now that are making blue light blocking glasses for people with migraine. Now the LA lamp, which we have a special code that's in the chat. If you want to buy it, they're giving us a discount code. I don't remember how much it is, but anyway, they're going to mail this out to the winner. So the winner is
Dana Wallace, it looks like.
Dana Wallace. Are you still here? If you are, you need to unmute yourself. If you left, oh well. Dana, I'll give you 5 seconds. 5, 4, 3. She put something in the chat? Okay. All right, we'll keep going. Sorry, Dana. We need to get someone in this room. Melissa, iPhone. Melissa was on her iPhone. And Melissa, are you still here? Well, lucky for you guys, I don't know. Let's see, I think we got all the people in the room on the bottom. Move some of these up to the top.
I'm Melissa and I have it on my iPad. I'm not sure if it came up on my saying my phone or not.
There was a Melissa on her iPhone. Different account. Sorry,
Oh, okay.
Melissa, iPad. Sorry.
Darn it.
Sorry, but your name's still in here. That would be funny if you.
Robin Pippin.
Robin Pippin, are you still here?
I'm here.
Robin.
Oh, no, I'm okay. I'm on the phone as well, ma'am.
Okay, well, where are you from, Robin?
I am from Maryland.
Okay, well, congratulations.
Thank you so much, ma'am. Thank you.
You're gonna love this lamp because you actually can just put it by your bedside too. And even if you're just hanging out at night and you're having a headache attack, you can always
Thank
use
you.
it.
That will help with
and-
the migraines greatly.
Okay, let's hope it helps you. And so I need you to also take down my email address and send me your address. Okay, my email
will.
is shirley@milesformigraine.org, not .com, .org.
.org. Thank you.
So I just want to say, for those of you in the room, your consolation prize is to take that food home with you. Please take something with you, seriously, because I'm on a plane tomorrow. I can't take anything. I want to thank Sarah for speaking today, and Dr. Collins and our other two doctors that have left us now. I want to thank all of you for hanging out this long. I know we're all tired, but hopefully it was worth it. I just also want to say that if you liked anything here today, if you want to consider making a donation, you can go to our website. You can go to Venmo at Miles for Migraine. All our programs and services are free, and we want to keep it that way. All of our funding from our walk runs goes to headache fellowship programs, such as the one Dr. Collins is in. We need more headache specialists. So even if you don't make a donation, please come to our walk, because it's the only way the public is going to really wake up and notice that this is a very disabling disease. It affects so many of us and people that we love and care about. And the only way we're going to get change is for all of us to do our part. Our doctors can't do it for us. We have to do the advocacy piece, because that's what they did in the breast cancer movement, and that's what they did in the AIDS movement. And that's why those diseases are funded so high above migraine, but we can do it. So thank you all for being here. It's a pleasure to meet all of you. And people online, thank you for joining us too. And hope you have a pleasant rest of your day.